Afternoon here, so it must be night there, no? You're ahead
It's
of
about
us.
six, sorry.
Okay. Evening.
It's a
Three,
little dark
two,
outside.
1. We are live now.
Good afternoon, everybody. Myself, Dr. Vishal Dave, Medical Advisor, Intas Pharmaceuticals, based at Head Office, Ahmedabad. On behalf of Intas, I would like to welcome you all for this Perfection Series webinar on the topic endoscopy for the gynecologist. Get the focus right on 16th April 2024. Before starting the webinar, we would like to have a lamp lighting ceremony.
शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तु ते दीपज्योतिर्नमोऽस्तु ते शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः.
Now, I would like to introduce Dr. Monica Singh. Dr. Monica Singh, consultant reproductive medicine, Bhopal Fertility and Endoscopy Center. She is also professor at Ellen Medical College, Bhopal. She is managing committee member, ISAR. She is also West Zone Coordinator, Medical Disorders Committee, FOXY. And also she is convener of ISAR Perfection Series and convener of FOXY Symbiosis Series. To you, ma'am.
Thank you, Dr. Vishal. And welcome to the 13th episode of ISAR Perfection Series under the aegis of Indian Society for Assisted Reproduction, President Dr. Amit Patki and Secretary General, respected Dr. Asha Bakshi Madam, under whose patronage this series is being conducted. We try to make it every 4 to 6 weeks, and we are at present on the 13th episode. This is a dedicated episode towards endoscopic procedures for the gynecologist and how can they get their focus right. For this episode of Perfection, we have a galaxy of star speakers, Professor Zaiming from China, who is one of our respected foreign faculty for today evening, who has been kind enough to consent and given us 30 minutes of his time for his talk. We have Dr. Nikita Trehan from Delhi, who will be speaking on laparoscopic cervical cerclage. We have Dr. Manjula Angani from Telangana. Madam will be speaking in rejuvenation techniques in gynecology. And we have Dr. Sangam Jha from AIIMS Patna. Besides this, we have a very dynamic and interactive panel discussion, which will be moderated by Dr. Kalyan Barmade, Dr. Dhaval Bakshi, and Dr. Ajay Haldar from AIIMS Bhopal. We have a galaxy of panelists also, some of whom are veterans and very knowledgeable about this subject. So I'm sure we are going to have very clear take-home messages, especially about, the use of endoscopy, the appropriate use, the procedures, the validity, and what the evidence say. So before we start our scientific session, I would like to formally thank Dr. Nandita Palshetkar, Madam. Can I have a CV, Vishal? Dr. Nandita Palshetkar is immediate past president of ISAR, past president of FOXY, and past president of IAG. She is one of the leading gynecologists of India with decades of experience, bestowed fellowship honoris causa from RCOG. And Madam has not joined today, but she is the person because of whom we could start this series in 2023. Next, I would like to thank our President ISAR, Dr. Amit Patki, sir. Dr. Amit Patki has taken over as the president of ISAR. He is a very renowned figure in the field of assisted reproduction in India, working as Medical Director, Fertility Association, Mumbai, as well as Honorary Associate Professor, KG Somaiya Medical College and Hospital. Sir is also consultant at Khar Hinduja and Surya Hospitals, Mumbai, country representative Aspire, governing council member ICOG, president ISAR at present, and has been also very active in MSR, MOGS, and RCOG. He has had several publications in national and international journals, many book chapters he has written, edited books, and at present he has got 2 international patents in infertility and stem cell research and is a renowned TEDx speaker. welcome Dr. Amit sir. Sir will be joining us shortly. I would like to next thank Dr. Asha Bakshi ma'am, who is Honorary Secretary General of ISAR. And Madam has brought about very new and fresh changes in the look and the execution of ISAR Perfection after taking over as Secretary General. She is also the key figure behind MP IAG and MP ISAR, because of whom we have been able to carry the state chapter activities with aplomb. She is always lending a helping hand to the state as being a very prominent member of the advisory committee of PCPNDT. Indore is well known for the number of conferences it has hosted under the guidance and leadership of Madam, including the recently concluded new AGCon conference, VP conference, the AICOG 2022, and many other conferences. Madam has got many awards to her credit. Ma'am, we are waiting to hear from you and get your blessings, please.
Thank you very much, Monica, for the kind introduction. And it's indeed nice to see such a good gathering, such a good participation, and so much enthusiasm from all over. And this series is doing very well, and keep it up. And I would like to really congratulate you, Randir, Manisha Jain, Neetu Mishra, Purva, all of you. And today I would like to congratulate Dhaval also for taking the initiative and coordinating all the things. And we are very fortunate that we have an international speaker, Dr. Wong, who is young and very dynamic and has kindly agreed to give his talk, and Dr. Manjula Anagani and Dr. Nikita Trehan. And I'm sure the panel discussion by Dr. Kalyan Vermande, Dr. Dhaval, Dr. Haldar is really going to get lots of learning points, and we are going to learn lots of things from today's webinar. So I wouldn't waste a lot of time, and I think you should get going.
Thank you, ma'am. Next, I would like to welcome our Chairman, Embryology ISAR, Dr. Charudat Joshi. And we are very proud that this time both are, ISAR, Secretary General ISAR and ISAR Embryology, both of them belong to MP. Dr. Charu Joshi is a stalwart in the field of embryology in India. And he is not only a postgraduate in life sciences and doctorate in life sciences, but also trained in ART and allied procedures from all over the world. And he has served as key office bearer in several societies like ISAR IFS ACE, ISSRF, and ISPAT. We welcome you, sir, and we are waiting to hear your few words and opinion about this series.
Thank you, Dr. Monica, Dr. Ranjit Singh, for organizing such fantastic series of webinars. And I think that this is a good initiative taken under leadership of Dr. Patki and Bakshi Madam to start with this series of webinar, because as an embryologist, I am already planning to have many webinar series in field of embryology. And the best part is that this is a nice way of keeping ourselves updated, what is happening in the field and what new is coming and what is now not in practice. So I think this is a very good initiative you have taken, and I hope this will continue after a break, as you are saying that this is for this season, this is the last webinar. So we'll have such good webinars in coming time also. So all the best to team and thank you very much. And I would like to thank all our speakers, faculties, and international speakers for giving their valuable time and joining this Perfection series. Thank you.
Thank you, Charu sir. And definitely we'll come out with a very fresh and new format very soon. I'm going to consult a lot of my team members, including Asha ma'am, and reveal that format soon. I also like to thank my co-convener, the backbone of the series, Dr. Randir Singh, who will be joining us shortly. Next, I would like to welcome and pay regards to Dr. Fessy Lewis, sir, who has joined as Managing Committee Member ISAR and also a Senior Coordinator of ISAR Perfection Series. So he brings in a lot of inputs from his experience, from his expertise. And we also know him as Foxy Vice President years 21 to 22, ISAR National Executive Member, ICOG GCM member 21 to 23, and also has number of important key posts in Kerala chapter of IAG, Kerala chapter of ISAR, and KFOG. We welcome you, Fessy sir, and we would like to hear a few words from you, sir.
Good evening to all of you. First of all, let me congratulate for this excellent effort taken by Dr. Monica and Randhir for conceptualizing this concept of perfection series. As you all know, this is the 13th episode, and I think you must have, those who have been hearing the previous series knows that each topic, the important of that area is being covered. Today, as you all know, it is endoscopy, and whatever those who are really interested in that topic and those who want to get perfectionized in that area really can attend that, because we know that lot of number of webinars are there, and it is not only useful for the practicing gynecologist or especially those who are having interest in infertility, and also for the upcoming postgraduates and upcoming gynecologists who are interested in this infertility field. So without wasting time, let me wish once again all the success. And as Dr. Charudatta told that, we hope that it will come in the new format. We will take all the suggestions what here now the audience have has given. So that we will be incorporating that in the coming series. Wishing all the best for today's episode of ISAR Perfection series. Thank you. All the best.
Thank you, Pesi sir, and we really acknowledge your contribution to ISAR Perfection right from the inception of the series to the final episode today. And next, I would like to, has Manisha, Dr. Pratik has joined because he did not receive my call in the afternoon. So we will be
So Madam Sir is busy in OT right now.
Right. So Dr. Pratik is again our, ISAR managing committee member and very renowned gynecologist from Bhopal, from Mumbai, and ART specialist. And he is also the senior coordinator of ISAR Perfection series. Now, I would like to welcome, we are delighted to welcome our chief guest for today, Dr. Pandit Palaskar sir, and I'm thoroughly, indebted to sir for saying yes to our invitation in just 1 second. He's always so humble and always so accommodating to all our demands of all our juniors, So Dr. Pandit Palaskar, I'm delighted to introduce us as the immediate past president of IAG year 2024. We saw a grand conference in Varanasi with Ganatra sir and Pandit sir, and it was a pleasure to be there all 3 days. We know about him, his skills. He's a lead gynec endoscopic surgeon and IVF specialist at Endoworld Hospital, Aurangabad, which is IAG and AAGL recognized Center for Training in Endoscopy, as well as a teaching hospital for DNB candidates, as well as a FOXY recognized training center for endoscopy. So I encourage all juniors who want to, hone their skills of endoscopy to please be in touch with sir and, get all the expertise. We know he's invited as operating faculty and speaker at all conferences in national and international scenes, and he has published several papers in national and international journals of endoscopy. We welcome you, Pandit sir. And we would like to have a few words from you, please, sir.
Hi, good afternoon, everybody. First of all, thank you, Dr. Monica Singh, and all the OPS bearers of ISAR, Dr. Amit Patki, Dr. Asha Bakshi, Dr. Fishy Lewis, and all the members of the managing committee of the ISAR for giving this opportunity to be part of this webinar. ISAR always comes with unique ideas, and this time Dr. Monica and Randhir has come with this idea of perfection series, where they organize the single theme-based webinar every weekly, and really it is very beneficial to all the members who are aspiring to learn the art of ERT and endoscopy. In today's era, I think endoscopy and infertility, they work hand in hand to give the best results to the patient, and really they are inseparable from each other. When we want to practice infertility in the patient-friendly way, we have to take the optimum benefit of the endoscopy for the diagnosis, management, and the treatment of the many problems that are as a fertility enhancing surgery. It is very useful, and today they are very uniquely chosen the best speakers will deliver the best possible outcome from these endoscopically manageable diseases. So I am very happy to see all these speakers and faculties, and I think this is very useful all the participants who are joining all over the India and the abroad, and they will definitely get benefited from the knowledge of this endoscopy. So I wish you all the best for this webinar, and in future also we are always there with you. Thank you so much.
Thank you, Dr. Palaskar. It was a
Thank you, sir. Thank you, sir.
many thanks, sir. And now I welcome our guest of honor for today, who is also president of IAGE, Dr. Atul Ganatra, sir. Sir, congratulations for taking over this great organization, which you are going to take forward, miles and miles under your leadership. Sir is also been the vice president of FOXI in the years 2021 and member managing council MOGS, VP IMA Mulund. Sir is working as consultant obstetrician, gynecologist, and gynecological endoscopist at Fortis Hospitals and Jupiter Hospital, Mumbai. He is director of Ganatra Nursing Home and director of Progeny IVF Center. Sir, we would like to have your address, please.
Well, first of all, thank you very much for inviting Pandit and myself here from IIG. Our boss, Ashish Kale, is sitting there. Ashish sir, namaste. So,
Namaskar.
Monica and Dr. Randir Singh, I was just going through the program just now. We have lots of friends on screen, Dr. Sneha Fesi. In fact, because we think endoscopy is something that cannot be separated from IVF, or IVF cannot be separated from endoscopy, our first conference on 8th and 9th of June is called the HIS conference. It's about hysteroscopy, infertility, and sonography. I think these three are a part and parcel of each, and I'm sure you will get the brochure very soon. Amit Patki, the president of ICR, myself, and Dr. Jaideep Tak and FOXI, we are all amalgamating the conference on 8th and 9th of June because we think we cannot separate IVF and endoscopy or ART and endoscopy. And please come in and see to it that this conference is a success. I'm sure once you see the brochure, you will realize we've carefully chosen our speakers. And I went through the program. It's a very interesting program, and I'm sure delegates will benefit. And I think the purpose of every organization is to do two things. One is to train the juniors, and another is to spread academics. And looks like that this Perfection series is all about spreading academics. It's a no-nonsense program. And I wish the entire fraternity all the best. And thank you very much for having us here.
Thank you, Dr. Atul. And I really like that tagline, no nonsense program. I think there's the first time some dignitary has spoken that, and it's so forthright and it's so, fresh sort of statement. I would now welcome Dr. Sneha Bihar ma'am, who is also a guest of honor. We know Sneha ma'am since very long. She is popular all over Maharashtra, all over India, and she is our favorite candidate for VP FOXI West Zone. Best wishes, madam. We know her as AMOX chairperson of emergency obstetrics right now, 24 to 26. She has also headed AMOX chairperson medical disorders committee, been very active in JOGI, national expert UNICEF, adolescent trainer, WHO FPAI certified worker, GCM governance council member.
Thank you, Monica. That should suffice. Thank you so much.
Madam, we are waiting for your address, ma'am.
Yes, very good evening to one and all. In fact, my respect and regards to all the seniors here. It's indeed a matter of pride and privilege to share the dais with the stalwarts in the field of gynae endoscopy, Dr. Pandit sir and Atul sir. Definitely, of course, thank you so much, Dr. Monica, for the love and affection shower. Thank you, Dr. Amit Patki sir, Madam Asha Bakshi, and all the managing committee members of ISAR for the invitation. Thanks, dear Dr. Randir Singh, Manisha, Prajakta, and all the coordinators. Hearty congratulations to you, Dr. Monica, for the well-designed program. Dr. Xiaoming Gong speaking on the transcervical resection of myoma, Nikita speaking on laparoscopic cervical cerclage, and Madam Manjula speaking on the regeneration technique in gynec, and of course the laparoscopic management of cervicovaginal atresia. very interesting panel we have from Dr. Kalyan Baramde and Dr. Dhaval Bakshi with expert as Dr. Ajay Haldar. I'm sure this is going to be a very informative and very useful program. So once again, I thank and I recognize the presence of many friends here, Dr. Ashish Kale, Dr. Priya Gupta, Dr. Madhulika Singh, and so many others, Archana Basir, and so many other friends. So thank you so much once again for having me here. Thank you so much for the invitation, and please do support and bless me as your candidate for Foxy Vice President. Thank you so much.
Thank you,
Thank you,
Sneha.
Sneha ma'am. Thank you, Sneha ma'am.
All of us, our best wishes are forever with you, ma'am, and God bless you, ma'am. And next, I would like to hand over the program to my three budding coordinators and very, very dynamic girls. We have Dr. Manisha Jain, who is Treasurer of Bhopal OBGY Society, member of MP Chapter of ISAR. We have MOC Dr. Neetu Mishra, who is Associate Professor AIMS Bhopal. And we have Dr. Purva Badkur, who is Assistant Professor, Department of OBGY, GMC Bhopal. I could not have taken this program or any webinar episode forward without the constant, cooperation, dedication, hard work of these three girls and their bright ideas. So I hand over the program to them and we start our first session.
Thank you so much, Monica ma'am, for those kind words. And I really feel privileged and honored to share the dais with all the galaxy of speakers and stalwarts present here of the endoscopy. And with the blessings of all the seniors today, we like to move ahead with our academic session. The first session is by our international speaker, Dr. Xiaoming Gong, sir, who will be speaking on transcervical resection of the myoma. And to chair this, his esteemed speaker, we have again two very senior chairpersons with us, Dr. Ashish Kale sir and Dr. Monica Singh ma'am. Dr. Ashish Kale sir is already a very well-known figure all over Maharashtra and India. We have been listening as sir just addressed him as the boss of endoscopy. I welcome you, sir, today. He is currently the chairperson of the Family Welfare Committee, FOXY, and has held various posts in Pune Obsgenius Society, IAG, ISAR, and Maharashtra chapter. Amongst, I think none of the organizations left where he has not held any position. The recipient of various awards, the special to mention Champions of ISAR, Kamini Operation Award, Young Achiever Award, and again a peer reviewer of Jogi and SFO, member of various international organizations, and has contributed many chapters and articles to various journals and books. I welcome you, sir. We are really privileged to have you today.
Thank you, madam. Thank you for those words.
Thank you. Next chairperson, we have Dr. Monica Singh, ma'am. Again, is very well-known figure. You all know her. She is the convener of today's program. Very active and dynamic member of the Bhopal Obsgenius Society. Currently, the vice president of the Bhopal Obsgenius Society, and again the member of the ISAR. I welcome you, ma'am, and hand over the session to our chairpersons to please take it forward. Thank you so much.
Thank you for those kind words. At the outset, I'm really thankful to the this particular series, which is instrumental by Monica Singh and Randir Singh. And also, it is a baby of a ISAR. So I'm very much proud that I'm associated with the ISAR in my capacity. So today we are having an eminent speaker that is internationally renowned. I know him from the Facebook. We know each other for last couple of years. He is the co-founder of Y OBGYN Medical Group in China, head of the Uterine Fibroid Non-Invasive Treatment Center in Y Group, chair of China Medical Group Association from 2018-2019, former associate professor OBGYN department, and he is a former head minimum invasive section in Shanghai First Maternal and Infants Hospital. Faculty teaching in 2003 to 2015 in Department of OBGYN in Medical College, Union Medical College Hospital. He has a special interest in a non-invasive and minimal invasive therapy in fibroids and adenomyosis. And we are looking forward for deliberation from him. Over to you, Dr. Gong.
Hi, it's my great pleasure to share my experience to your society. And today, can I know how many doctors are online?
the faculty link is being used by just 22 people, but online we have more than 1,000 viewers, Dr. Gong, and the
Wow.
total list we will get after the program is over from our studio. So,
That's
and
a
then
huge
viewers in
number.
China
Yeah.
also.
Yeah. Yeah.
So,
I'm right now. I worked in the multiple cities in China. My family name Gong. So Xiaoming is my first name. Right now I worked as in the Woyi Medical Group. This is our OB/GYN group. Maybe it's the first one OB/GYN doctor group in China. So I used to work in a teaching hospital. So the Peking Union, which is the most famous hospital in China, also it's ranked as a #1 hospital in the Chinese society, and it was founded by the Rockefeller Foundation 100 years ago. So right now I'm focusing on the non-invasive and minimally invasive surgeries for fibroids adenomyosis. But today I want to share some of experience from Japan. I learned it from Dr. Lin, which is a very well-known expert in the myectomy, TCI. So first of all, I want to share this case. This is a very typical type 2 myoma. Patient is 38 years old, has a fertility requirement. This myoma from this MI, we can see it's a very, it's a FIGO type 2 myoma. It's about 5 centimeters. She had a heavy bleeding and have anemia. So what's our choice? At that time, she went to different hospitals in Beijing, and her suggestion for her is to do a laparoscopic mammectomy, but she refused because she wanted to find a new method for her. At that time, we also did a lot of the ablation therapy. I will mention about ablation therapy a little bit because right now in my country, we're using like a HIFU, high intensity focused ultrasound, and also we have an MR guide HIFU, and we have a microwave, the radio frequency. So she went to see us because she want to do ablation. But when I look at the myoma, and it's very close to the endometrium, so I said that a better way is to do a resection. But can we do this such a big myoma with a hysteroscopic resection? No, in the past, the answer is no. But after I visited Japan and also learned this technique, it's a yes. So everybody know about this type 2 is a very difficult myoma because it's the majority of the part is inside the uterine wall. So when you do the hysteroscopic resection, it will be very hard to do it. And also it has many complications like overfluid or gas embolization, and also some perforation, especially when this the myoma is the medial part is close to the serosa, and the chance of rupture is high. So if we have such kind of myoma, can we do it? When I first know Dr. Lin is from this textbook of the hysteroscopic application in the clinical use. It's translated. The original version is in Japanese. We translate it. Has a Chinese version of the textbook in the hysteroscopic section. So in 2017, I visit his center in Japan. So this is Dr. Lin Baoliang. He is Taiwanese, originally from Taiwan, but he went to Japan and stayed there for his rest of life. So right now he's almost 70 years old. At that time, when I visited him, it's about 7 years ago. He's in his 70s. So his city is located next to Tokyo. It's a city called Kawasaki. And I went to his workshop when the APAGE had meeting in Osaka at the time. So the workshop is excellent. I learned the technique and then learn his instrument. So after the workshop, I went to his center for a week. I learned the technique. So right now, I know this technique. We call it a Lin's method for do the TCM. With this method, it's very different with the traditional way to do the resecting TCM resection. In the past, we do the TCM piece by piece. We use a rope to resect the myoma. And you know, the difficulty thing for us is sometimes it takes longer time, and also it needs a lot of fluid when you do the TCM. And also one of the most difficult thing when you get to the border of the myoma, sometimes it's very hard to differentiate from the myometrium. So that's one of the issue we encountered in the past. But right now, with this Lin method, we can do the resection completely. So the method is different. It also can decrease the difficulty to do the resection. But also, from my own personal point of view, it has many disadvantages, especially the instrument. When I returned to my country at the time, I don't have Lin's grasper. This is the most important thing for his method, and we also don't have this 30 degrees of resection root. And also for most centers, they just have a monopolar resection root, and sometimes it's you know, for the overfluid issue, it's dangerous. Dr. Lin invented some instrument. This is a 30 degree of the resection root. So it's actually, you know, the angle. Usually our resection root is a 90 degree, but this one is a 30 degree. So you can use the loop to dissect the myoma. Also, he invented this is the most important grasper. We call it Lin grasper. For the steps, I think that maybe we can see from these videos. So this, let me turn off the. Yeah. So the first step is we need to right now I do the resection with this Olympus or sometimes other brands of the loop. With this use resection needle, open the capsule. The first step is we use this the needle to open the capsule of the myoma. The second step is different with others. So this one, when we get to the down part, this when we get to the end part of this, we try to get to the space of the capsule. So this is a little different with the past. So when you get to the space, you know, usually with the myoma, it's easy to find the capsule, to find this space. The space is very clear. You can see the myoma is here, and the myometrium is it has a space in between this capsule. So we use this resection needle to open this space. Sometimes with energy, sometimes no. We just push our resectoscope and try to push the myoma into the uterus, into the uterine cavity. So try to gradually turn it to be a type 0 or type 1. So when we do the resecting with this resecting needle, we try to notice this angle, try not to perforate the uterus. So this step is the most important concept of this resecting. This is another one, and sometimes we can also use the rolling ball to push, and sometimes, you know, you got it in bleeding. We can use this rolling ball to stop bleeding. But usually with this rolling ball, it's very easy to enlarge the space in nuclear this myoma. So from this video, you can see we push into this space. So until we get a first like a 2/3 or 4/5 of the part of the majority parts of the myoma into the space, into the uterine cavity, so we do the next step. So the next step, we will try to use this resect needle to cut the myoma into small pieces, So this is the step. We do not resect it into little pieces. So we just cut in rough. So we can use the link grasper to get the myoma. We cut from the different direction. So right now, because the myoma is isolated from the myometrium, it's relatively easy to do this cutting, and it's safe, and it doesn't damage the endometrium too much. Okay. This myoma after the pre-treatment with the GnRHA, the myoma shrinks to 4 centimeter. This is the patient we saw in the second slide. So it's originally it's 5 centimeters, but right now it's turned to be 4 centimeters in size. It's still very big. It's still very big. Okay. Okay. When we finish the cutting, so the next step we try to dilate. We try to dilate the cervix, so as much as possible. So usually I will pre-treat the cervix with Luminera, so to make it soft and open the cervix. So it depends on how big is the size of the myoma. The largest one I can find in my country is a Hegel size of 25. But if for myoma is about 3 centimeter or 4 centimeter, usually I just dilate it into the Hegel size of 16. 16 is usually is good enough to do the remover. So this step is very important. You can guess it's you want to remove a mass inside the uterine cavity, but if you didn't open the myoma too much, if you didn't open the cervix too well, it was very difficult to remove the myoma from the uterine cavity. So the next step is we try to get to the space, get to the myoma, and we try to rotate it. As I said in the previous talk, the majority of the myoma is isolated. We still have some part of the myoma is connected to the myometrium. So we use this link grasper. Link grasper, we don't have link grasper in the past, but right now we have some manufacturers get the link grasper, and Dr. Lin is very generous, and he just asked me to name this grasper as link grasper. So this is it's his invention. So we can have this kind of tools, and this one you can see from the ultrasound. Usually we have abdominal ultrasound. My assistant will help me to locate the myoma and locate the grasper. And if the myoma is very big, we can use the loop to do the resection. If it's not too big, that's okay. We can just use the grasper, and with the grasper, we can with the grasper to get the myoma. And sometimes we can also use this tissue removal system. This is MyoSure, but as you know, China and India are both are not very rich country. Many people, they cannot afford it. But I just want to show you in this video. So in some cases, if you get troubled to remove the myoma from the uterus, this is a method we can decrease the size of the myoma. Okay. So the majority of the myoma is removed with the grasper. This is another case. I will tell you that this is a very interesting case. This patient, she had a 13 centimeter of the myoma inside the uterus. So after we dissect, we use our grasper to just remove the myoma piece by piece. So you can see we don't need to use normal saline or water fluid too much. The majority of the myoma was removed with our grasper, so it's safe. With the ultrasound guide, you can safely remove this myoma. Okay. Well, today I think that I had a little grasper always doing like with me myself. So today I just have one. I want to show you this little grasper. So you can see here. And this is grasper. Now we can hold the myoma from the tip. The tip of the myoma is we can with this tooth. It's very strong tooth. Without this strong tooth, we cannot hold the myoma very good. Ring forceps, no, this is not good one. So this is another case. So after resecting, after dissecting, and we try to remove the myoma under the abdominal ultrasound guide. And this patient, that's an early video. So in this patient, you can see in the beginning, the cervix is not dilated well. So this patient is only dilated to Higgs size of 12. So you can look at the process of the removal. It takes a long time, and sometimes it's risky, and it's a very you need a very strong strength to pull the myoma. I always kidding that I said it's a man's job because it's very you need a lot very strong. But later on, I think there was a big dilator, we can move it easily. But right now, the cervix preparation is very important. Without good cervix preparation, you cannot dilate the cervix well. So if with a very difficult cases, you need to prepare the cervix. Right now, I can choose dilate with mifepristone for 3 days. If her oral mifepristone for 3 days, and usually the cervix will tend to be very soft. Okay, so finally we get this myoma tissue with this grasper. So this is another video. So after this is the one 3 centimeter located in the posterior in the fundus of the uterus. So after the MySure, it is very easy to remove this myoma with our grasper. See, easily, very easy. It's after remove some part of the pieces. Okay, it's very easy. So always remember to guide it with ultrasound. It's very important. Okay. After remove the majority of the myoma, and then we use a loop and we try to resect the residual part and also remove these small pieces from the uterine cavity. Okay. And the final step, we always put a balloon. The balloon size, it's related to the size of the myoma. If the myoma is big, then you need a bigger balloon. If the myoma is, usually we just use a regular Foley tester, and sometimes we use this kind of triangle. It's a triangle balloon. It's a Chinese local companies made it. and it's most suitable for those patient with a fertility requirement. If the patient has a fertility requirement, they usually keeps its balloon for about 1 to 2 weeks to prevent adhesion. If the patient have no fertility requirement, they will remove the balloon on the second day after surgery. So this is a good figure. Let's say the bigger size of the myeloma, the volume is bigger. So do remember, it's not just like a 4 centimeter of the size compared to the 2 centimeter. In the volume, it's about 8 times bigger. So do remember, the bigger the size of the myeloma, you need more time. Also, you can find this figure with this research. You can see it takes much longer time if the myeloma is bigger than 4 centimeter. So we try to shrink the size to 4 centimeter as much as possible. The other thing is you need to look at the distance between the myeloma capsule and the serosa. We call this serosa myeloma thickness, SMT. The best SMT is greater than 5 millimeter. If the SMT is too small, the chance of rupture would be greater. So do remember to scan the patient before the surgery. Try to find the suitable cases for you. And this kind of laminaria, I'm sorry, my English is not good. Laminaria, because this product right now is not available now. In the past, it's available in Chinese market, but two little doctors in my country use this one. But I found this one is very good. But for the dilation of the cervix is very good. So cervix preparation is very important for the big myomas. Also, ultrasound monitoring is very good. It's very important. But for the successful of the myoma removal, you need this grasper. You need this. You need always need this grasper. Without this, you cannot do this surgery well. Also, need a bigger dilator. Okay. So this is my experience. So I just want to share a new video that is I just did last month because why I want to share this video. That's it has 2 myomas. I want to just let you know it's possible. Make it things not possible to possible. So right now I think that with this method we can remove a big myoma. So this is a video I want to share with you because it's has 2 myomas. One is one is 8 centimeters in size. The other one is the other one is 3 centimeters in size, but it's the first one. Oh, sorry. Let me share. It's let me share the MR image first, so you can. Oh, sorry. This one. Okay, this one. So this patient, she had a multiple fibroids. She had a one history of the TCIM in other hospitals, but not finished. There was a majority part of the myoma was left in the uterine cavity. Before the surgery, her fibroid size, this is type 0. It's about 7.8 centimeter. Also, she had another one, 3.5 centimeter, in the uterine wall. So usually for this type 2, this one is type 0. So with this kind of myoma, it's very difficult. We pre-treated her with the mifepristone for 3 months. However, the myoma didn't shrink in size. It's still about 7 centimeters in size. So we start to do the resection. This is many links grasper right now I can have in the Chinese market. And right now, we can see this is a very huge myoma. It's about 7 centimeter. So when we get to the uterine cavity,
sorry to interrupt you.
You're not able to see the video.
You cannot see this video?
No.
Oh, sorry. Then let me how to share my screen again. Okay. Can you see it now?
Yeah.
Yes, sir.
Very.
Oh,
Yes.
okay. So let me share the MRI image for this patient again, because this patient she had one. This myeloma is type 2. This one is type 0. So this type 2 is about 3 centimeter, 3.3 centimeter in size. This one is very huge. It's about 8 centimeter. So let's see how we start to do it with this method. So this is the scope, and when we enter the uterine cavity, we can see this is a huge one. So the fundus is located in the anterior wall. This is the live surgery I did last month in our local meeting in Shandong province. Okay, so the first step, we need to open the capsule. How many minutes do I have? 10, right? Okay, let's see the most important step. So this is when we see it, and we start when we finish checking, and we start to do the section. So this is a huge one. Okay, this is type 0. So the first step, as we do for the type 2, we always get to the space of the myeloma. Okay. The needle angle should be parallel to the capsule. Okay, so this is the beginning, but you can see from this 8 minutes, and we use about 5 minutes to do the dissection. When we do this kind of resection, you need to set your pressure not too high. So when we see the bleeding from the uterine the uterine wall, it's good. It's good because it's mean that your pressure is not too high. Otherwise, you need to worry about the fluid imbalance. But the LINX method, this good thing about the LINX method, you don't need too much fluid to do the dissection. So you just we start from 8 minutes. This is unedited video, so it's real time. The whole procedure takes about let's see. Okay. Almost finished. So with abdominal ultrasound, we know where are we. So almost when you isolated the myeloma, the majority part of the myeloma was isolated, then we can start to use our grasper to locate it. Because this myeloma is huge, although it's type 0, but still it's takes about like 7 minutes to finish this TSA the dissection. So the next step, this is a Collin speculum. This is very good for design because you can remove the instrument from the side. Okay. So the next step is we try to dilate because this myoma is very big, 8 centimeter. So we try to dilate the cervix as much as possible. So this is the largest one. We dilate it to pupil size of 25. With the mifepristone pretreatment, the dilation is very easy. This is 24. And now it's 25. Okay, so this the next step, we start to use the grasper, the link grasper. Try to reach the myoma under the abdominal ultrasound guide, and we hold it. And try to rotate it. So when you see the myoma is totally freed from the myometrium, then we can try to pull it from the uterine cavity. Okay, we finished with the first one. This is about 7 centimeter in size, and we move to the second one. The second one is very hard because it's in the this type 2, and it's located deep in the myometrium. So we need to use our ultrasound to help me to find this myoma. It's a you can see over here. You can see the capsule, and because we treat her with mifepristone for 3 months, the endometrium is sick. So without the abdominal ultrasound guide, we probably cannot find this myoma easily. Okay, but right now we can get to the space. Okay, see, this is the capsule. This is the capsule. So when we found the capsule, and we use the needle and also the scope to push, try to get to the space and enlarge the space. And gradually, this is broken, and then we change another one. Okay, so so get to the space. My time's up.
शेवटचं
My
चाललंय time.
My time's up. Okay, so let me finish that quick. So that's the most important step, is to try to push the myoma into the uterine cavity. This is with abdominal ultrasound. You can see we're working here. We try to free this myoma from the capsule, and gradually we will get to the uterine cavity. So when we dissect the myoma, for third majority part of the myoma is get into the uterine cavity, and then we use a grasper again and try to hold it. And okay, so it's the same step. We use the grasper, get the myoma, rotate it, and take it out. So as the cervix is already dilated fully, so it's very easy to remove this 3 centimeter inside myoma easily. Okay, because I don't have much time, I will just finish this step. Okay, got it. So the final step, we stop bleeding and we'll put a balloon inside. Okay, let's finish this video. So the final, I want to share some of the new technique we are doing now is we call the ablation. So ablation therapy is actually we use a very thin 16 needle. We try to insert abdominally from the abdominal wall or through the vaginally. We can gradually we can use the energy to ablate this myoma. Why I want to share this experience? Because this new technique, we can right now 80% of my ablation will use the microwave. So I will share you one story, one patient. This patient, she had a 9-centimeter myoma.
Your chairperson, you can take 10 minutes extra, sir. You can continue your talk.
Okay, almost finished. That's the last case I want to share because this patient, she is a 9-centimeter type 1 myoma, and you know, for us, if we want to do the with TCM, it's not possible. It's not possible, right? So in the beginning, when the patient came to other hospitals, they want to do open surgery or want to do a laparoscopic surgery, patient refused. So when she came to me, I give her the Zoladex Genitri, high dose for 3 months. After the 3 months of the Genitri, the myoma shrink to 6 centimeter. And at that time, still not possible with the TCIM. The best TCIM indication is less than 4 centimeter. So I tell her, we try to do ablation for her. So with this ablation, we can shrink the size. So after ablation, some part of the myoma was destroyed. So later on, we do after another 3 months, the myoma decreased to the size of 5 centimeter. So 5 centimeter is okay, but it's still very difficult. So we use the resectoscope, and but the principle is the same. Principle is the same. So we finished this case in one step. So finally, this myoma was resected with hysteroscopic resection, 75 grams. So it's a huge one. So right now, combined with microwave ablation, TCM can be achieved with difficult cases. So I think that may change the way we do the hysteroscopic resection in the future. So I've almost finished my talk. I have many videos on the YouTube or on my Facebook. If you like, you can have a look. Thank you.
Yeah. Thank you, Dr. Gong. It's been a wonderful videos what you've shown it to us. There are the 2 points I wish to highlight on here. You can dissect the capsule by using a simple hysteroscopic scissors, and if it has been achieved, and you can just do a pressure effect of the hysteromat, wherein the hysteromat higher pressure and lower pressure, which automatically causes the myoma to pop into the uterine cavity, and it will become more easier for to do total evacuation of the myoma from the bed. Don't you think like instead of using this particular bipolar needle, the Caesar also would have been done the same job?
Yeah, Caesar is low efficiency. You can see this one, this patient, because she has a fertility requirement. So I opened the capsule with the Caesar. So, but later on, I still use the resectoscope because it's a low efficiency with the Caesar. So later on, when I open the capsule, I will change. In the beginning, I use the Caesar, but later on, I still use the resectoscope. For the pressure, I think the most important thing is, first of all, you need to have a good view. If you don't have a good view, bleeding always, you cannot see clearly. So it's first of all, you need to see it clearly. The second important thing, don't set the pressure too high. Usually I can start the pressure around 100 milligram.
Okay, when you are doing a dilatation of the cervix, don't you find the dilatation to such an extent will cause the cervical incompetence in future pregnancies to carry?
till now, I didn't find this problem, but many people will ask me about this question. But I think that you know, you for the patient who has a vaginal delivery, it's the for the cervix, it is about the same, but we need to dilate the cervix gradually. So luminaria is very important. This one can dilate the cervix gradually with this one. Yeah, I think that this one is right, but I feel, you know, right now China's the Chinese company, they didn't import this luminaria from the US now, so we have our local brand. It's not so good.
Okay, thank you. Dr. Monica?
Thank you for the wonderful talk, Professor Gong. It was really, you know, your videos were mesmerizing, and we were just wondering at the control you had, your eye over the ultrasound and resectoscope in your hand. So what about the fluid management in such patients? Have you ever had problems in managing the input-output the fluids?
After I know the LINX method, not anymore. In the past, I did have a problem with, you know, when you use the resectoscope to cut the, you know, the resectoscope is very tiny, only like 3 millimeter. So with fibers of like 4 centimeters, it takes a long time to do resection. So we have the problem with the fluid. But as you say, with that the huge myoma, we need just about 8 minutes to finish cutting, and the pressure is not too high. So after that, you know, you just you remove with this Glasper. This Glasper is more at this step. You don't need water. So we don't have any problem with fluid deficiency after we start to use this step. So that one, the one with 13 centimeters of myoma, we after we dissection, we just start to use the Glasper to get the myoma out from the uterine cavity. So it takes me about 1 hour to remove the myoma, but without water. You see?
Yes, yes.
Okay.
So you avoid using the fluid there at that step?
Yeah, at that step, I don't use water.
Yes. And that the outer edge of the myoma has to be more than 5 millimeter away from the serosa, you mentioned.
Yeah, that's we call it the SMT. SMT. This is a serosa myoma thickness. Is
yes.
Right now the smallest SMT I did is 2 millimeter. You know, when I do the when I did this case, you know, you are trembling. you can understand. It's very easy to rupture if you don't be careful about it.
Any incidents of infection with the laminaria, Professor?
No, never.
Okay. Thank you so much. And I'm sure all our viewers and audience all over the world have benefited. And for record, this lecture will be on YouTube for anyone who wants to watch it later. And thank you so much, Professor. Now we move.
Okay, hope you can like it.
Thank
you.
Thank you. So one question, do you have any experience with the new shaver devices that are being used for myoma resection? Any role? This new shaver devices that
Bugatti.
Yeah.
The shavers have come now, Professor. The shavers, which, you know, are being made by stores and Bugatti shaver and all, very expensive devices to shave out the myoma. What's your opinion on that?
Yeah, I use a shaver for multiple polyps, but for the myoma, you know, it's a low efficiency. You know, Dr. Bugatti is in Shanghai now, and for that case, you know, the 7 centimeter myoma, I will ask him that he went to the same meeting with me. I asked him if we can use the Bugatti shaver to do the resection. I want to he perform when IBS surgery. He said, no, this is too big. Also, so you can understand for the experienced doctor, I prefer to use the resectoscope. But for the beginners, for those not good at the resectoscope, it's better with, Bugatti Chiron is safe. You don't have too much chance to rupture the uterus, so it's easy. But the efficacy is low. So for big myoma, it takes longer time, and also has you cannot remove it in one step sometimes.
Thank you so much. Thank you so much, Professor Gong, for
Thank you
that.
so much.
You're
talk.
welcome.
And let us start the second session, Dr. Manisha.
Yes,
Before,
ma'am.
before that, I would like to welcome, I'll take 1 minute to welcome and felicitate Dr. Pratik Tambe, Managing Committee Member ISAR, and our Senior Coordinator for ISAR Perfection Series, who has joined us. Dr. Pratik, you're most welcome. And he is highly decorated ART specialist from the city of Mumbai. He has headed organizations like ICOG, ICRM, MOGS, ISAR, MSR, and is always a mentor, a very friendly person, mentor and guide to many of us. Welcome, Dr. Pratik. We would like to hear a few words from you, please.
Thank you very much for inviting me, Monica, and apologies I was stuck in the OT today. So ISAR Perfection Series has always set the benchmark ever since its inception last year. I'm very pleased that this series is going on and it's ably headed by Dr. Monica and Ranveer Singh. They choose fantastic topics. They have eminent speakers from all over the country and also internationally. And some of the most recent advances and the cutting edge technologies are being showcased in today's program, which is an endoscopic surgery. I'm also an endoscopic surgeon, but only part-time, main bread and butter on KRT. So it's always wonderful to see fantastic speakers. Dr. Gong's presentation and amazing videos. We have Nikita up next, and I'm very pleased to be chairing Nikita's session. Thank you very much for inviting me.
Thank you. Thank you, Pratik. Now, we can start session 2, Manisha.
Yes, ma'am. Thank you so much, sir. Thank you, chairpersons, for chairing the session. Thank you so much, Dr. Ziongo, for taking out time and managing the time overseas. Now we move on to the next session and very important topic on laparoscopic cervical surcharge with Dr. Nikita Trehan, ma'am, from Delhi. And to chair her session, we have two esteemed chairpersons as Dr. Narendra Gupta, Dr. Sugandha Chopra, madam. I think she's busy with some emergency and she's not able to connect with us. I take extreme privilege and honor to welcome Dr. Narendra Gupta, sir, who is currently the chairperson is our Rajasthan chapter and is also was the past secretary of the Jaipur Obs-Gynae Society. He has been the editor of the Infertility Update newsletter. He has been invited to various national and international conferences and is a very avid and very senior experienced gynecologist of the city with more than 2 decades of experience. Has published various papers and is a member of various international and national organizations. I welcome you, sir, today for today's session. And I'd like to
Thank you, Dr. Manisha.
Yes, sir. And I'd like to hand over the proceedings to chairpersons to take over.
Dr. Manisha, I'll just take 1 minute. Dr. Pratik is also chairing this session.
Okay.
So
I'm extremely sorry. I'd like to welcome Dr. Pratik Tambe, sir, as our next chairperson. Thank you, sir, for joining at last minute. Sir has already been introduced. He's such a very senior, very humble, and very academic person. And we are always blessed to have his experience with us. Thank you, sir, so much. And I welcome both the chairpersons over to chairpersons to take over. Thank you so much.
So the topic for today is laparoscopic cervical cerclage. And it is my privilege to introduce Dr. Nikita Trehan. She is the Managing Director of the Sunrise Hospital. She is a renowned gynec and laparoscopic surgeon dedicated to gynec endoscopy and MIS at Sunrise Hospital, India and Dubai for the last 20 years. She holds the world record for the largest fibroid removed laparoscopically of 6.5 kg. She also holds the world record for the oldest person operated in 107 years of age. The patient had a vaginal sacrospinous fixation. She's a keen academician involved in most gynec conferences and workshops for demonstrating her superb surgical skills live. She has organized and conducted several CMEs and conferences on minimal invasive gynecology under the banner of Sunrise Keyhole Surgery Foundation, of which she is the vice president. She has also trained many national and international doctors, Indian and international doctors in endoscopy, and has been a training surgeon for minimal invasive gynecology. So I request Dr. Nikita Trehan to speak on this very important topic, that is laparoscopic cervical cerclage. Dr. Nikita, the stage is all yours.
Thank you so much for that kind introduction, Dr. Narendra. It is indeed a pleasure for me to be here this evening and talk on this very important subject of laparoscopic encerclage. I'll just share my screen. Just tell me if everything is visible.
So slides are visible.
Right. So at the outset, I'd like to thank Dr. Monica, Dr. Asha Bakshi, everybody at ISAR for having me here today. So coming on to cervical incompetence. What is cervical incompetence, and when do we say that it is cervical incompetence? We all know that we've all studied this from our MBBS days, that a painless second trimester loss of pregnancy is called it can be attributed to cervical incompetence. Now, we had history indicated cerclage and ultrasound indicated cerclage in our green top guidelines. So basically what happens here, if we see an ultrasound over here, this is a pregnant uterus and this is the fetal head, and you can see this is the cervical length. The process of labor starts from the internal os. Then the contractions keep on happening. Then this lower part will dilate. Then more contractions, then the lower part dilating. And the last part to dilate will be the external os. So when we put a McDonald's stitch, we put it at the external os, wherein it's fairly futile. In genuine cervical incompetence, you will have this entire cervical length will be dilated, and only the last part will be there, and that will obviously many times in genuine cervical incompetence fail. So where should we have a stitch placed in cervical incompetence? We should have a stitch placed at the internal os, or at least in the mid-cervical region like a Shirodkar stitch. So either at point B or at point A, but never at point C, which is what all of us are doing here regularly, like McDonald's stitch. So indications for lap encerclage, like I was saying, green top guidelines we follow, which are history indicated cerclage, which is history indicated is 12 to 24 weeks miscarriages, 2 miscarriages, or preterm labor. And ultrasound indicated is when we can see this image, that is the funneling and dilatation of the cervix. You can see here, you can have a U-shaped funneling, you can have a V-shaped funneling. All these things may prompt you to do a rescue cerclage. At Sunrise, we're a center of excellence for emergency cerclages. So we get cerclages right up to 26 weeks of pregnancy, referred from everywhere, because lap encerclage can be life-saving for the baby. So one of the things where you do it prophylactically. Suppose you are doing an interval cerclage. So you have a history in the previous pregnancy, or you have, in the previous pregnancy, you had a radical trachelectomy for a CA cervix, or you have already proved that there is incompetence, especially one of the Mullerian anomalies, which we very frequently associate with cervical incompetence, is a septum. So in the septum, of course, miscarriages happen because of the septa, because it's avascular, and you have decreased steroid receptors there. But also another reason for miscarriages in a septum is cervical incompetence. In fact, most of the Mullerian anomalies, we do find cervical incompetence. Are my slides visible, Monica?
Yes, they are. Yes, they are.
So herein I'm presenting one of the case, which is at 20 weeks of pregnancy. She had come to me for a encerclage. Now, in history indicated, or if we know, we can put the stitch interval also, and we can plan it and put it after her first trimester screening, because ultimately you want to save a normal pregnancy, that the baby is normal. So once you have a first trimester screening, or you've done an NIPT, then you know that the pregnancy is normal, and then you can put the cerclage stitch at 14 weeks, 12, 14 weeks at that time. And or this is a rescue cerclage at 20 weeks. So herein what I'm doing is, I've put the primary porter Lee Wangs. Now I'm putting my 3 trocars, which are standard procedure. In a pregnant uterus, you cannot manipulate the pregnant uterus. So because you can't use a manipulator, you can't use a myoma screw. So it becomes very difficult to handle this extremely vascular pregnant uterus. So what we use is, on my right side, my assistant has used a bowel grasper, and all she's doing is she's retroverting the uterus. I'm using, from my left port, I'm using a tooth grasper and elevating the bladder and opening the vesicovaginal fascia, pushing the bladder down. So as you can see, is this visible? This is the right-sided bowel grasper, which is just pushing the uterus down, retroverting the uterus. I'm pulling this up and opening this bladder fold and pushing the bladder down. So because you need to see, in non-pregnant time, we do lual many times, uterine artery clipping, many times in fibroids, etc. But in pregnancy, stopping the uterine blood flow to the fetus is a disaster. Because once you do that, then you will have FGR, you will have accreta, percreta, all kind of placental anomalies in the baby. So you need to go medial to the uterine vessel. Once you go medial to the uterine vessel, encircle the uterus, then you will be doing a perfect cerclage. So how do we obtain that? I open the broad ligament windows. So here, this is a Sunrise method. We've been following this since 2013, and we've done hundreds and hundreds of cases while doing this in India and in Dubai. So what we're doing is, here and you can see anterior leaf of broad ligament is being opened. So here I'm putting a grasper from the posterior to the anterior leaf of broad ligament, opening the broad ligament window, to protect any other structure like bowel or anything coming in between. So I've opened the broad ligament window. Now you can see the uterine vessel very clearly. Dr. Pratik, can you, is the video clear with you? Are you able to appreciate the uterine vessel?
Yes, ma'am.
We can see,
It's all good.
very
Absolutely
clearly,
fine.
Nikita.
No.
It's very clear.
You know, because I'm just slide the next slide. So here you can see, again, I'm repeating the procedure on the other side and opening the broad ligament window on this side now. The grayish area which you see is the area which will tell you that this is the area where you have to open. Again, you see my assistant is putting a grasper from the posterior part of the broad ligament, coming anteriorly, and similarly you open this window. Subsequently, you take a Marceline tape and then cut off one edge of the Marceline tape and pass this needle here. Here I'm passing this on the left side, anterior to posterior. Now I can see the entry and the exit point of my needle. Is that clear? So at the internal os, you can see the entry and the exit point of the needle. Hold it right there. Withdraw the needle and then pass the tape onto the other side. So that way your uterine vessels will be completely safe, and you will not, there is another technique called Sue technique. In some people, they are not able to pass this medial to the vessel and they passed it lateral to the vessel, which was called as a Sue technique. So the issues which they faced are gross placental anomalies and FGR in the baby, especially accreta percreta. So we prefer to go in from here. Now this tape immediately is being handed over from posteriorly to the right side. And again, this needle will be passed from posterior to anterior with the knots anteriorly. Now, there are lots of issues which can happen, technical, which is during the procedure, and otherwise also during this procedure. So what are the things which you should be wary of? So this needle, you have to, like I said, entry and exit points you have to see of the needle. Suppose while entering, you may put on the stitch little above or little below. You have to put it exactly at the internal os. Suppose by mistake you put it at the lower uterine segment, means you have put the stitch little above where you had to. So this stitch will become useless because it'll not prevent her cervical incompetence. Hence, at Sunrise, we standardize the protocol. And what I do is I do an intra-op ultrasound to check my level of the stitch, that where is the stitch exactly? Is it exactly at the internal os, above, below, whatever? Because if it is above, then it will be a futile stitch. So here you can see you tie 4 to 6 knots anteriorly. And all this little bleeding which you're seeing is because of these small vessels, and that will stop as soon as you finish time. And you can see here intra-op ultrasound, and it is clearly at the level of internal os. We put 2 stitches. We put 1 stitch at the internal os to prevent preterm labor, and 1 stitch at the external os. The external os stitch is essentially to prevent the loss of the mucus plug. The mucus plug is very important for her to not get any infections, any ascending infections which can come. So the purpose of that is not to prevent preterm labor, but to prevent ascending infections. Of course, when you do surgery in pregnancy, there's risk of anesthesia to the woman. There can be traumatic leak. There can be other issues, but the advantage is that you have already checked that the baby is normal. You've done a first trimester screening, and then you're putting it. Interval, of course, is easier. Even my fellows put an interval cerclage, and it's a fairly easy, straightforward procedure. But the disadvantage of that is that if at all she has in the next pregnancy a second trimester issue or a congenital anomaly which comes up, you'll have to cut the tape. If you have a first trimester miscarriage, you can do a suction evacuation up to 12 weeks in the next pregnancy. But in case you have later than that, 12 to 24, at that time you will have to go and cut the tape, which you could cut by a colpotomy, or you could do a redo laparoscopy and cut the tape. You don't have to take out the tape. You can cut it at any one point. So here, this is the case. These are the complications which can happen. It would be completely unfair of me to not show you what complications can happen and how to manage them. So this is a pregnant uterus. This is a 24 weeks pregnancy wherein we are going to do a lap encircler. This happened in Dubai. And you can see the trocar went and hit the uterus. And there is bleeding and bleeding and bleeding. So first thing is, do not panic and clean your screen properly. Vision is essential. Don't go and rush. By the time you rush and think of doing a laparotomy, it'll be over. Always think of laparoscopically going and holding the bleeder. So this, you can see here, this was the bleeder. So I've just gone and caught the bleeder with a grasper, then cleaned the camera, done suction. And once you've got the bleeder, then you have 101 methods. You can use bipolar, you can use other things, or take a stitch even onto that. So your vision should be clear. So the first thing is, do not panic. Get a clear vision. See, now you know that it was such a small bleeder. All you had to do is use a bipolar, coagulate it, and then proceed with your lap encirclage. Another case had come to me with, while doing the surgery, this is the case where it was twins at 19 weeks, and my mistake, overconfidently, and instead of putting a grasper from posterior to anterior, I put a harmonic from posterior to anterior, and you can see how the uterine is bleeding like a tap. So again, do not panic. Hold the vessel. Put a 10 mm clip and nothing will happen. It'll stop in 2 minutes. So these are complications. These are my own complications. I have created this complication, and I know the mistake I made also. I went with the harmonic from posterior to anterior. I should have put a grasper and anteriorly opened the broad ligament. Because I made that mistake, I paid a price for it. And also remember that you are not the one who's paying the price for it. The patient is. So at the end of the day, mistakes happen with everybody. Provided you can handle these complications, keep a 10 mm clip and hemostats always ready on your trolley. This is a thing which I'm really fed up of. These are cases which come to us. Many times it comes that they are referred from different places in North India, Moradabad, Muzaffarnagar, here, there, everywhere, Punjab, everywhere they come. And by the time they come, I get this bag of membranes. Now, if they were referred earlier, then we could salvage the baby. This is the tricky part. When they are referred with this bag of membranes, then there is a chance of choramnitis or triple I. So what is triple I? And when you have choramnitis, then you may have to cut off the tape and let the baby go. So I request everybody who's watching this webinar today that don't let your patient reach such a late stage. And you can put a McDonald's and pack her and send her for an internal cerclage also, so that at least there's no bag. And when there's a bag, we put a worm stitch. So this is triple I. Nowadays, we do not use the terminology choramnitis. Nowadays, we use the terminology triple I, that is intrauterine infection and inflammation. And that happens when the amniotic fluid, placenta, fetal or fetal membranes, and the decidua get infected. And this has proper criteria. The criteria are fever more than 39 degrees, leukocytosis in the mother, fetal maternal tachy, and of course, if the purulent discharge is there, you can have that checked. But what do we do routinely? Ye sab textbook hai. What do we do routinely in our practice? What I do in my practice is that when I see a bag, then I do a amniotic fluid aspiration, check for the WBCs in that amniotic fluid. If there is a low glucose and there is a high WBC count, more than 100, I do not do a cerclage. Maximum, I will do a vaginal cerclage as she wrote kar. Lap and cerclage means it's going to be completely futile. So you have guidelines, but how to translate that into your practice is extremely important. Again, if you're putting a cerclage with a bag, make sure that you watch the lady very, very, very carefully for any signs and symptoms of choramnitis. If she has choramnitis, or you know she's choramnitis and she's 26 week, or you've managed to pull her up and she's come to 26, 27 week and she has choramnitis or a high leak, how will you manage this lady? So basically, you can salvage the baby still. You can give steroid cover. And for steroid cover, one of the new kids on the block to stop the contractions at that time is atosiban. I simply love this drug atosiban, and it has worked very, very, very well since the time it's come. Stops all the contractions for 48 hours, which gives you enough time to give your Maxelf and your steroid cover and attain fetal lung maturity. So this is one thing which I would say again should be there in your pharmacy to be used at any time, because all the other things will, all these things, the Rytodrine, everything is a isoxsuprine, all things are things of the past. They don't work half the time and they cause a lot of maternal side effects. So atosiban is a very good drug, and it has worked very well in our units. And a good fetal unit, suppose you want to do an intrauterine transfer. So a good fetal unit also, where they can salvage 700-gram babies, you can use atosiban, give steroid cover, give Maxelf for neuroprotection, and transfer the baby if you're not equipped, intrauterine transfer, in case you're not equipped for handling such a small baby, or if you are equipped for handling the baby, then do it and keep her with you. Now, if there is a high leak and there is no choramnitis, suppose there is a high leak and woman is absolutely fine, how long can you continue with the pregnancy? Again, these questions are asked to us many, many, many times. So you can continue with pregnancy even with very minimal or nil LICA, because all those things, or Potters and all those things which we hear, limb contractures, all that rarely happen. The baby will keep on making urine now, and that will keep on coming as amniotic fluid. So one of the things which we do now, we've recently started, is a stem cell plug. So we inject stem cell into the membranes, and that seals the plug, and it has worked in a couple of cases. We are doing a study on that. I would be in a position to share the results of my studies within a year, because right now we're just still recruiting and making the protocols. I've just used it right now only in 3 cases, stem cell, but all I can tell you, it has worked. It does stop the leak. Earlier on, we were using cryoprecipitate, but that somehow did not work. Stem cell is very promising. This is another lady. She had come to me. She had a lap and cerclage with me, and she had 3 pregnancies after that. They kept the tape. I, of course, kept the tape, did 3 cesareans, and kept the tape for the next pregnancy. Then she came to me with this vaginal discharge all the time. So mesh erosion, mesh going into the cervix, all these things can happen. This is a foreign material. So once her family is complete, suppose you're doing a cesarean section, and you ask her, do you want more babies? And suppose she says her family is complete. Then in that time, take out that tape. You can just cut it, and it'll be, that knot part is the one which goes in. So you can see, you can see the tape coming from the cervix. So this is an example of mesh erosion into the cervix. And she did not want more babies also. She had 3 of them after this tape. So family was complete. You can see that mesh going in. So take it out completely. Do not pull out this tape from the uterine. Suppose it's gone inside the uterine vessel and you pull it out, it can avulse the uterine vein. That is something near the uterine vein. You should be a little more careful. This is another lady. She had previous 5 miscarriages. I had done an internal cerclage. This lady came to, she was admitted in the hospital with torrential contractions. And you can see, we imagine that if the contractions happen, there'll be a bucket handle tear wherein the cervix will go down and the uterus will go up and the uterus will be divided into 2 parts. Aisa kuch nahi hota hai. What essentially happens is, with increased contractions, the tape comes inside the internal canal, into the cervical canal, and it becomes loose as soon as it comes into the cervical canal. So you will never have a tear which will divide the uterus into 2 parts. This is just an example to show you. Again, I'm telling you, these are all complications which I have faced in the last 10 years since we are doing this in cerclage. So 1 in 4 is not a statistic. It's me. Please speak about recurrent pregnancy loss. It's a real thing. The trauma which a woman goes through with preterm labor, with recurrent pregnancy loss is really sad. So thank you very much for the patient listening. Any queries, concerns, I'll be happy to answer.
Thank you, Dr. Nikita Trehan. I think that was very instructive. Your entire series of cases, your personal experience, and you spoke from the heart. That is something which is different. A lot of people demonstrate videos, they show surgery, they show skill. But the way you're invested and you're emotionally attached to your patients, and as a surgeon, you've also shown us the complications which are. Everybody shows good things. Nobody admits their mistakes live on air, on YouTube, and nobody actually shows you how to tackle those complications when they happen. So hats off to you. Amazing experience and amazing cases and surgeries. It's wonderful to have you here with us on the ISAR platform, and thank you very much for joining us.
Thank you so much, Dr. Pratik. Coming from you, it's a huge compliment.
Dr. Nikita, congratulations for that lovely talk. I totally agree with Dr. Pratik that this was a very, very forthright and very frank talk you had. Like it was a talk in which you spoke about all your experiences, good and bad. Now, when you put that needle in the bulging bag of membranes, does that needle itself, the prick, does it close, seal, or does it lead to more leakage of amniotic fluid?
What you're trying to say, what do I do in these cases? See, initially, in our initial days, what I was doing is I would put the internal cerclage first, then come down and put the external cerclage for the bag of membranes. So what used to happen is that more bag used to come down. So now I've started doing reverse. So what I do now is I do a worm stitch. So I first go vaginally. I put a McDonald's vaginally. Do not touch that bag. Bag should not be touched at all. You're going around the bag. And then second stitch, you're taking a worm stitch. Worm stitch is where you occlude the cervix. Okay. So first a McDonald's, then a worm, and then go laparoscopically and put the stitch. What will happen is that the bag will go up a little, but you will find some amount of membranes as you follow up these patients, some amount of fluid and some amount of membranes between the internal and external loss in her pregnancy.
And that fluid you test for the sugars and the WBC count.
Any of that. When you are checking, okay, these are 2 different questions which are being asked. First question is how we will prevent that bag rupture or whatever by first putting a McDonald's, not touching the membranes, and we're preventing choramnitis, and then putting the worm stitch and then going up. Second question is, patient has come to me in my OPD. She has come with a bag of membranes and I need to know whether she has choramnitis or not. She has tachycardia, she is visibly sick or whatever. So what I'll do is, under ultrasound guidance, on the abdomen, I'll do a amniocentesis. I'll take that amniocentesis fluid and WBC. It will be checked in my lab only to see whether if it's more than 100 WBCs, or if you can see under the microscope the gram stain or low glucose count, then you know that she's already in choramnitis. So this entire procedure is futile and will risk the life of the mother.
Yeah. So you do amniocentesis per abdomen, like the routine amniocentesis.
Amniocentesis.
Yeah.
Anything that's contaminated site.
And all this you do under your favorite drug is atosiban to reduce the contractions. All
This you're doing because she's going into preterm labor.
Yeah. So you use
She is proven.
Yeah.
So like I said, we get even from bigger hospitals here, people come in their ambulances, they send them here, we do the encerclage and send them back. See, the advantages are manifold. Once you put an internal cerclage, then you don't need all that bed rest, all the other restricted mobility, all those other things. Only with a bag, when there is a slight amount of LICA still present between the internal and external os, you may choose to put her on bed rest. Otherwise, there's no role for bed rest and all restricted mobility for the patient.
Thank you. Thank you, Dr. Nikita. Any other questions our faculty has?
I think we're good and we're already delayed. The next session speakers and chairpersons are waiting. Thank you again, Monica and Ranveer, for inviting me. Congratulations, Nikita. Fantastic stuff. Let's move to the next session.
Thank you. Thank you so much, Pratik.
Thank you, Dr. Pratik Tambe, sir, and thank you, chairpersons, for chairing the session. Now, for the session, I'd like to hand over the session to my co-MOC, Dr. Purva Badku, to take over the sessions. Over to Purva now.
Hello. For the next session, I invite Dr. Madhulika Singh ma'am and Dr. Priya Gupta ma'am. Dr. Madhulika Singh ma'am is presently president of Varanasi Society. She is senior consultant gynecologist, hysteroscopist and laparoscopic surgeon at Shivam Hospital, Varanasi. Her areas of special interest is in infertility, hysteroscopy, endosurgery, laparoscopy and colposcopy. Madam has held many executive posts in Varanasi OBGYN Society. She is an active member of NARCHI. She has to her credit the fellowship of FIEC MCH. She has been chairperson for many ICOG conferences, and her special interest is in promoting researches in infertility management. I welcome you, ma'am.
Thank you so much for your kind words.
I also welcome Dr. Priya Gupta ma'am. She is presently president of Kota OBGYN Society. To her credit, she held various executive posts in Kota OBGYN Society as vice president, secretary, and organizing secretary Raj Gynecon 2017. Presently, she is treasurer of Age SR, managing committee member Age SR, West Zone coordinator, Family Welfare Committee, managing committee member IAGE, an active member of ISAR and Society of Fetal Medicine. I welcome you, ma'am.
Thank you so much, Purva.
Thank you. Now I invite you, ma'am, for introducing our next guest speaker. Thank you, ma'am.
Yeah,
Over to you,
sure. I should introduce?
Yes, ma'am.
Hello?
Yes, ma'am.
Okay. Good evening, Honorable and the most revered President, Dr. Amit Patki, immediate past President, Dr. Nanta Parishkar, and Secretary, Dr. Asha Bakshi, and Chairman Embryology, ISAR, and Honorable Management Committee members. Respected Chief Guest, Dr. Pandit Palishkar, Guest of Honor, Dr. Atul, and Dr. Sneha, and and we have respected Masters of Ceremony, Dr. Neetu and Dr. Manisha Jain. I thank you from the bottom of my heart for giving me this opportunity to share this platform on this webinar. I feel honored to welcome you all. The next topic is vaginal regeneration consists of forming up pervaginal skin and vagina canal to improve the sexual fitness. It can be classified according to etiology. It depends.
Can I just interrupt here, please? My talk is not vaginal rejuvenation. My talk is regenerative techniques in gynecology.
Okay, they have given me this. Thank you. Sorry to say that.
Yes,
So
it's ovarian and every regenerative gynecology.
Okay, sorry. Because what I have seen, it was written this. No problem. So I would like to invite the Honorable Speaker, Dr. Mrs. Manjula, Founder President of IG Telangana Chapter, and I welcome you to deliver your talk on this topic.
Thank you. Thank you. And thank you, everybody. It is an honor and privilege to be a part of it. Thank you, Dr. Monica, Dr. Manisha, and Honorable the guests and the chairpersons. And I would like to share my screen right now. And this up one. And share. Hello, okay, fine. I need to just do that. 1 second. Just give me a second, please. I think I forgot to do the changes.
To say a few words about Manjula Madam, I can introduce her in a different way. She is one of the pioneer in this field of regenerative gynecology.
I don't know, Ashish. Thank you for saying such wonderful work. I just changed my Zoom thing, and suddenly everything went wrong. But anyway, I am going to share my screen right now. Yep, now it's coming. Right, and share. I hope you can see the slides. Can you see the slides, please?
Yeah, madam, it's visible right
so my
now.
whole topic is regenerative medicine. That is like taking you all to back to the future. It's about, is it the present or is it the future? For me, innovation is not necessarily a new thing which has to be started. It is about already we have something existing and something which is another thing which is existing. And if we can make two things together and give a new way. We just heard Nikita speaking about cervical cerclage in interval and emergency. So it is just, we know that cerclage is existing. We know that recurrent pregnancy losses exist. And we do know the abdominal cerclage is important. Then putting a laparoscopy into it is what is the innovation, and so many changes how to avoid complications is the innovation. That's where the regenerative medicine has started. And it is our quest for innovation which has got us to here. So what is regenerative medicine? It replaces RRR. South Indians, especially Telugu people, are famous for RRR, the movie which got the Oscar for us. So it is replaces, it regenerates, and it restores. So is it a fact or a fiction? We are looking at therapies where we can also give cure to the thing. So that is what you look at. What is rejuvenation? We do know that as a child, when we fall down, we have a skin which is scraped, and within 1 week, we have the skin which comes back again. So it has a body's natural ability to heal itself. We have so many times we have seen typically on the walls, that is the lizards, it sheds its tail, and again the lizard start developing its own thing. That's where the organ replacement happens. So when it happen in a lizard, can it happen to us that we don't have to look around for the trees or something for the organs? So the center aims how to overcome the ongoing donor shortage, to avoid the need for immunosuppression and challenges for rejection. Then the third comes regeneration. So we know about rejuvenation, we know about replacement, but this whole concept of regeneration helped us to be where we are in infertility, that is in the ovarian rejuvenation and the endometrial regeneration. Here, we are looking at how to restore the function of the organ by regenerating its own epithelium, so which can be the cell-based therapy by using cell factors, that is growth factors and PRPs, like in bone marrow or whatever, what they've been using. So we are looking at where we can give a definitive, affordable healthcare, which allows the body to heal from within. So it looks at different cell types. So we are looking at how we can look at cell products where the PRP and growth factors can come. Stem cells can be embryonal, adult, and induced pluripotent. That is where the whole world is looking forward for. But can we do it autologous or mesenchymal? Do we need a cell bank to do mesenchymal? And what are we looking at? Are we looking at anti-inflammatory action, or are we looking at immunomodulation? Every time we need different thing. So if I'm looking at anti-inflammatory action, I would look at autologous bone marrow. If I'm looking at immunomodulation, more of mesenchymal stem cells. This is where we stand, if to put it in a nutshell. So clinician perspective, as a clinician, what I look at, what is the basis, what to use, where to use, how much to use, and exactly how to use. That is a technique. And will it work every time? And what are the outcomes? These are the questions which I need to answer myself before I can talk to you guys. So this has been a RCOG scientific impact paper in 2012. When we started doing it in 2013-14, I looked at this paper and I said, when people are trying out in all these things, why can't I start using it? Since then, we have used it in infertility, Asherman's, POF, PCOS, genitourinary syndrome, rectovaginal fistulas, and lichen sclerosis. Trust me, it works. Majority of the times, 80 to 90% it works. We just have to know how and how much to use and how the technique to use. Nikita also spoke about PROM, where we are also using it, the stem cells and the PRP into the PROM to stop it. We just used it only in 2 cases, so we'll have to wait and watch, like she said. 1 case we could stop, 1 case continued into delivery. So therapeutic applications of PRP would be for gynecological, reproductive, urogenital, and in aesthetic, that is reconstructive and gynecological and dermatological. So I look more for gynecological therapeutic application rather than the aesthetic. When it comes to stem cells, if you look closely, we use it in perimenopausal, postmenopausal lichen sclerosis. Till now, we were only using Humazone. We know that it is precancerous. People can go into vulval cancers, and we had estrogen and Humazone or only as a treatment. Now, PCOS, can we do something at the PCOS so that we can get over so many of the metabolic syndrome and cancers, where India became the capital of cancers now? Next, in infertility, for ovarian reserve improvement, where it is worsening, the quality of oocytes and endometrial regeneration with Asherman's and endometritis increasing. Then you have perineal syndromes, which again, quality of life is what is important. With the age of the life of the woman increasing, we look at how the perineal syndrome should come down with a thinning, atrophy, and everything. Rectovaginal fistula, as of now, I have not used it, but I had friends who had used, and they said, yes, 1-2 cases it worked, 1 case it did not work, so they're sending it for surgery. So coming to infertility, let us go one after one, where it works, how it works. We do know 10 to 20% definitely have infertility, and PCOS is one of the commonest cause. How can I look at in PCOS, and what are we looking at in ovarian in regenerative medicine? We are looking at improving metabolic disorders and therefore outcomes, reproductive outcomes in pregnancies. So there has been a lot of research which says that we can maneuver the androgen producing gene. So you give the stem cell, this bone morphogenic proteins molecules will downregulate the androgen synthesizing genes. Hence, the ovulation and the implantation rates and the outcomes completely, and the inflammatory gene comes down, and the folliculogenesis and the transplantation also will definitely be improved. So this is something which we can look forward in all the PCOS if the regular treatment do not work. So to put it in a nutshell, in PCOS, it is inhibits the anti-inflammatory by inhibiting the macrophages, neutrophils, and B cells, and immunomodulatory by improving the T helper cells. And how does it do it? So that's how it goes on. Coming to reproductive biology, we all started getting interested into it by revolutionary idea of neo-oogenesis, because ovarian stem cells are cultured into mature oocytes, which when taken in a very smaller stage, even now people do it. And then White et al. Said that germ stem cells have a capability of forming oocyte-like structures. But from then, we had lots of studies which came out, say that for refractory Asherman's, yes, it is engrafting which works. And even in men, the azoospermia, in cases of testis, the spermatogenesis do happen. So mesenchymal, what happened till from then to now? Mesenchymal stem cells are proven to renew the ovarian reserve. And this mesenchymal and adipose mesenchymals have an advantage because they're autologous, though no rejection. And what is important for any stem cell therapy is, are they in the similar cell line to that of endometrium? Yes, bone marrow stem cells, mesenchymal stem cells are similar to the cell lines of endometrium and oocytes. That's how it works. Second point, which is important, it is a subendometrial transplantation. If you look at the picture, it is the epithelial progenitor cells, which is in the basal layer, which is important. So the vascularity around the subendometrial layer is what is very important for us to get this functionalis layer to come into the proper way so it can sit on it. So over time, we know that menopause is not exactly the absence of the oocytes, but it is because of the somatic cell and the germ cell aging. So it's not the absence of fixed supply of oocyte. So it is the microenvironment around this which is making the oocytes hidden inside. They're hidden, they're there. We have to just get them outside by not tackling the oocytes. We're not doing anything to the oocytes. We're changing the environment, amicable to the oocytes to come out by themselves. So this is the way we started looking into it, where we can increase the angiogenesis, proliferation, and differentiation both in endometrium and the oocytes, and by engrafting in that. So recent research has clearly showed it is anatomical microenvironment, and within 2-3 weeks, not like 2-3 months, 1,000-fold expansion of cell number happens with these stem cells, and tissue regeneration happens. Possible mechanisms are so many. It is like, differentiation into function cells, anti-inflammation, immunomodulation, apoptosis, anti-fibrosis, paracrine. But I am looking at the primordial cell follicular activation by local environment change so that they become preantral, and I can take out even at preantral stage and start the outside maturation, and the oocyte can become, her own baby can come from it. So it is this ability which is important in ovarian angiogenesis and folliculogenesis. Since then, many studied, proved time and again. So imagine a world where pregnancy can come from an own egg in even POF. It's not just words. Let me tell our experience. Now, stem cell-based approaches into the uterus can be intravenous stem cells or extracellular vesicles or exosomes. More and more studies are coming with exosomes, intrauterine injection of stem cell and EV and exosome. And finally, in place of uterine transplant, the fabrication of synthetic graft into the thing and then transplant. So in a nutshell, if you can see here, you have bone marrow stem cells, adipocyte stem cells, and then endometrial stem cells, and even in the umbilical cord stem cell, whatever stem cell you want to use. You can isolate them, and you have exosomes, or you can have extracellular vesicles on the scaffold material, make them into uterus and put them back as a transplant, or give injection intravenous or into the uterus. You look at anti-inflammatory action, you look at neoangiogenesis, and finally the endometrial regeneration. It's very simple we look at, but actually also it happens like that. Coming to Asherman's, I will show you the whole video. Basal lamage is damaged, we know that. So it triggers inflammation, there's uncontrolled deposition, and mediator of fibrogenesis and fibrotic happens. So the first treatment is always adhesiolysis. Then the therapeutic result is something which is very bad because of our fibrotic element, where we look at this. So when it comes to the Asherman, we know that it is grade 1, 2, definitely the results are bad, good. 3, it is really bad. But even then we start getting the menstrual cycle and regeneration when it comes to this. Only in the tuberculous cases are the ones where we do not see much results when it comes to stem cells. So this is the way it is. I'll show you the video how to do it, we'll say it. Any type of stem cell can be used, bone marrow or endometrial or umbilical cord, equally good. I don't want you all to get thinking that that is better, this is better. But what are we looking at in Asherman's or in thin endometrium? When the bed is less, the zygote cannot sit. It will not attach itself. So we are looking at neoangiogenesis, anti-inflammatory, and immunomodulation so the implantation can happen. This is what we are looking at. So in nutshell, again, similarly with Asherman, there's destruction. We can use autologous stem cell or allogenic stem cell. Allogenic is something which is expensive. That is what we need to look at. So look at autologous, and we need a lot of stem cell guidelines when it comes to allogenic, but when it comes to autologous, zero. We don't have to worry about it. Please go ahead and do it, because we are not doing any cultures, and then do it. So with POF, because whole procedures I'll be showing in things. So I just want first, let me give you the understanding of why we use, how we use. So whenever there's decreased ovarian function, that is where we look at 2 leading mechanism of POI is follicular depletion and follicular dysfunction. So it also acts by and like different antifibrosis, angiogenesis, folliculogenesis, immuno. Theory is very good, but outcomes is what, like I said, as a doctor, I would look at. So these 3 points are important for primary ovarian failure. Yes, I'm looking at ovarian blood supply. I am looking at where to give. It should be going into the hilum. Third, it has to be given, we give it in the 2 different locations, one towards the ovarian ligament, second one towards the infundibulopelvic ligament. So this is the way we do for ovarian rejuvenation. Whenever there's low ovarian reserve or even POF or even postmenopausal, we look at it. But for a normal karyotype is what we are looking at. Rest of the reports are normal. This is our preliminary study, which is published in 2017 of the PRP. I will show you the video, how we go ahead and do it. These are streak ovaries. We go at one location in towards the ovarian ligament, and next towards the infundibulopelvic. We gave 1 cc of stem cell and 1 cc of PRP, both. So now we do both PRP and stem cell into the thing. Immediately the volume will start improving and you can just see the immediate change in the local milieu there. Then within 1-2 cycles, the biochemical changes start happening. So this is the way about the ovary. This is I purposefully showed you the thinnest ovaries. Otherwise, with low ovarian reserve, we could get better ovaries also. Whereas when it comes to subendometrial for Asherman's or thin endometrium, we have to make a multiple subendometrial punctures using a high frequency needle, 25 to 30 punctures. Then massage the uterus, and then under ultrasound guidance or just like IUI cannula, we just have to put this stem cell 1 cc and the PRP 1 cc into the uterus. The muscle, which is the 3 muscles, the living ligages, they contract and take this liquid subendometrially and leave that blocked for about 1 to 2 minutes. Then within 1 month, you can see we check the zone 3 blood flow in the endometrium and ovarian blood flow and the hormones in the second day of every cycle for the next 3 months. From 2014 to 2018, we have done 80 cases using only PRP. But after 2019 January, we do both PRP plus stem cells. So we looked at ovaries, endometrium, ovaries plus endometrium, and including HG, primary ovarian failure, thin endometrium, Asherman's, TB, septal resection cases, every case and any case we were doing it. The ET improvement is seen in 35 cases, and thin endometrium only patients had fantastic results, that is 13/16, and blood flow has improved in 42/50. So we have seen that blood flow has improved, still the endometrium has not improved in about 7 cases, and in FSH improvement is seen in 43, even though the ovarian blood flow is not improved in as many cases as we have seen. So this is how there has been a paradox in our improvement in supply, but in endometrium definitely more and more, and as we did that blood flow improvement has correlated well with the endometrial thickness improvement. Spontaneous onset of menstruation we have seen in all the patients initially when we started doing the PRP, and size improvement have seen in 5 or 5. Total pregnancies with only PRP, out of 80 patients we had is 13 patients. As we went ahead, we saw a lot of improvement in the menopausal syndrome. That's when a lot of discussions with everybody and literature search, and we started doing autologous bone marrow stem cell along with the PRP from 2019 January. This is our first publication of stem cell in 2016, where we started doing stem cell therapy for congenital endometrial aplasia. This girl went ahead, got married, and now we had given a boy baby for this girl. So the boy is already 6 months old. And then this is our, again, the original research which is published in 2021 about the bone marrow stem cell and PRP. So I will not talk more about the study because it is the same thing, what, like I said, measuring V and all, but outcomes are what I wanted to show. So this is the way we take out the thing under ultrasound guided thin endometrium and all. And I showed you how thin endometrium looks like. Literally, absolutely, we can see the blood supply and no endometrium at all. Then we use the gem shading needle and take out the bone marrow and then prepare it, centrifuge it. Then and there, the marrow stem cells are separated and then they are instilled either whether into the ovary or this. This is the way we do it. And results, 0 side effects. We look at blood supplies, like I said, and everything. So as of today, till March, we had total of 106 patients from January 19. Primary, secondary infertility, postmenopausal, ovarian failure, thin endometrium, adhesion, stem cells, only into the endometrium and all. Majority were in 31 to 40 years, and into both the ovaries and endometrium is about 63. We do only into endometrium when patients come to us from IVF centers, and only into the ovaries also when they want only the quality of the oocyte to be improved. So here is the correlation which we found, that blood supply improved in 75.5%. In the same way, endometrial thickness also improved in the 75.5%. Ovarian blood flow improved in 81.1%, but FSH levels improved in 87.3%. And mean FSH value have come down within second cycle to 10 FSH. And after that, especially menopause and POF, we had seen fantastic results. 95% of the patients have improved. In 7 patients, patient underwent second and third sitting also. As the results have improved, they wanted to get more and more done. And then we did give them a 54-year-old coming from 63, coming down to 8, going for IVF and giving a pregnancy. So this is the way we have done, but it is not a thing. So it's not that every patient become pregnant. After 106, we had Total 24 plus 6 pregnancies. 6 are ongoing right now. So total 30 pregnancies out of 106 cases, which we have done. Out of that, 3 were missed abortion, 21 delivered, 3 needed a second sitting for us to do it. But 30 out of 106, which we would have given up. That is what I would look at as surrogacy or something what we are looking at. Then the questions come. Is it really effective? Yes, but it depends on the technique and technology. Why is there ambiguity? Because people have not learned the right technique, when to do, how to activate. It is not just the giving, it is the activation, which is very, very important. How do we activate it? By keeping it cold, just before injecting into the ovary and the endometrium, adding 0.1 ml of calcium gluconate. These go a long way. And who has the best results? When there is no calcification of the oocyte, of the ovary, and who are not in the menopause at the early age definitely has a thing. And main consideration is anticoagulation of the sample when we are making it, isolation protocols when we are doing it, keeping it to the cold, like I said, a timing of activation just before giving it, and giving it exactly in the cortex, not in the superficially. This is all the technique which is important. And post-operative management. Are we giving GnRH? Are we giving growth hormone, aromatase inhibitors? We do give sildenafil. We do give L-arginine. So all these features, supportive treatment are very, very important. Even with low MH, we go ahead and do, because I'm looking at pregnancy now, not at the future. So her reserve is less. She's going to go in for menopause. I'm not bothered. I want her to become pregnant now. So this is what it is. So I would go ahead and do even in low MH with the quality and all. So does it work in every single woman? Like I said, no. But we should give it a try. We should tell them if we are looking at antral follicle count improving, very case-based. Zero AFC, yes, I would still do it because primordial follicles are not seen in the scan. I am not looking at preantral follicles. I'm looking at primordial follicles, which can grow into preantral follicles. So even with zero AFC, I would go ahead and do the procedure. Like I said, streak ovaries, I would do it and she would get back her periods and things. Quality, yes, almost all our patients, our 80 to 90% of the cases had good quality and IVF results coming out good. So I would suggest all of you to please go ahead and do it. Now coming to the other part of it, I'll finish in another 5-10 minutes. I know I have around 10 minutes, I think. But the other part of it is what I would look at. That is genitourinary syndrome. Because I want to you all to understand that regenerative medicine is not just ovarian rejuvenation and endometrial regeneration. It is a genitourinary syndrome and menopause, which is very important. That is, lack of estrogen is the reason why there is vaginal dryness. Estrogen helps, but not to that level of giving it the prevention from malignancy and the symptoms completely. Give gabapentin, it also helps. Do whatever you want, but this is the results which can happen. MSc is given one time, single local vaginal application also shows the results which it has to be done. So isolate whether it is adipocyte ones, or the bone marrow, or the PRP. I do a PRP, and I will show you the technique how to go about and do a PRP into the perimenopausal vaginal atrophy, dyspareunias, and the perineal syndrome with the burning perineal syndrome. So we take PRP. We take around 6 cc's of PRP with a long LP needle or a long needle. We just go ahead and give all over inside the vagina for the dry vagina, and in the perineal region also wherever we have to do it. So this is just the simple technique where we use, and once we do it, then within 4 to 6 weeks, the vaginal rejuvenation happen. We join this along with Emcella and also Thermiva, which is RF. So the results are very good when we give all these 3 treatments. Her perineal syndrome comes down, the pain comes down to 0. Today, one patient came back to said, and she's like, my pain, my perineal syndrome is 0. So it is like when we start grading from 100% to 60, 40, and 0, that's when we get the happiness of what we do. And lichen sclerosis, we know it is a precancerous lesion, chronic inflammatory skin disease. So this is something which we have to look at for anti-inflammatory and immunomodulatory properties. PRPs will promote it. Technique I have shown in. Now have a look at this particular lady who's been suffering with lichen sclerosis, itching, and she's like, after first Thermiva, this is the way it looked. After Thermiva, we went ahead and did the PRP into the, look at the whole perineal region where the lichen sclerosis was there. So again, 6 cc's to 8 cc's of PRP we gave all around in the vulval region, and then we gave the PRP. Within 1 sitting of this and 2-3 sittings of Thermiva, I will show you the results. And her pain, she used to have dysuria. Dyspareunia is out of this thing because they never had intercourse because of this. And dysuria, perineal burning, quality of life. She was perianal pain, and she had I mean, imagine the quality of life. That is what I would say, the pain scale and everything. So once the procedure of PRP is done in this particular area, and we can see how it looks after 1 or 2 sessions of this. One PRP, and within 3 cycles of TIBA, you can see the whole epithelialization happening. So this is the result, and symptomatically, she's 80 to 90% fine as of yesterday. She came around 2 days ago, and she says she's 80% rid of most of the problems, and 90% rid of the epithelial itching and all that. So I think one more this thing, and she's going to be completely fine. So this is the results which we look at. And now this is a lady who had complete vaginal adhesions, lichen sclerosis, and this thing, and with only PRP and no Tarbiba because it is external. Postmenopausal atrophic vaginitis with this, and you can see the result, how it looks within 1 sitting of PRP in 1 month. Complete epithelialization and absolutely no pain, no burning. So we need to pick up our cases. Quality of life of the woman is important. It's not just the obstetrics, not just the laparoscopy, not just the anything. Menopausal syndrome is real, and we need to understand, because life expectancy has increased, and we need to look at everything what we can help the woman with to make her life livable or quality of life improved. So rectovaginal fistulas can be congenitally acquired, and it has to be a small fistula. Spontaneous fistulas, Behçet syndrome, where it is the avascular necrosis, is where we can look at these things, where surgical management you want to avoid. Bone marrow and adipose tissue can be given first line therapy as rescue. Like I said, I have not used it. But yes, into the submucosa of the vaginal walls, people have evaluated after 12 weeks with 60% complete recovery. And I want, finally, it cannot be over without regenerative medicine in the neovagina formation. This is the Anagani technique of neovagina formation, where I want all of you to be, it is such an easy procedure that I want everybody to be learning it. This human body is bivalve. It's a raphe in the center. So on either side of the dimple of the raphe, we use a graded dilators on either side of the raphe. So first thing is the position. Pelvis has to be positioned into the hyperflexion phase of the thigh, and on either sides, as a graded Hegar's dilators go with the catheter on the above, and this in between, when we have the raphe, we cut it. So once we cut it, on the graded sim speculums next, we make it go towards the thing. So the neovagina, which is created, is in the natural planes of the God-given Langer's lines and the planes of the normal human body, and the normal angle of 45 degrees towards the flow. So it is a normal anatomical position is what we are achieving, to the 9 to 10 inches in length and 3 to 4 inches in the width. So adequate length, and created in such a way that the normal vaginal mucosa comes. We are not going to create anything where the mucosal ulcers can come or skin can come. Once this is done, the normal vaginal vulval mucosa is interned inside and sutured inside. So there is an epithelialization which happens, rejuvenation of this epithelium with this vulval mucosa happening in between the mold which I'm going to create now and the neovagina which I have created. So these 4 layers which I'm suturing will be the main anchor for the epithelium to regenerate between the mold and this. So this is how it will be created, where we can look at hemostasis is well maintained because we are gone into the natural planes. Then the mold which I create is by 8.5 number glove with 4 Vaseline gauze pieces. So we create this in a publication. I should have put it. This has been published in 2019 in JMIG. It is used by many people all over the world now. So this goes inside 3 gauze pieces is what I put. Then we create the mold. And this technique we show in many of the operative workshops in EAGL in Mumbai. Also, Dr. Prakash Trivedi has shown this technique. Now, this is an antibiotic cream which we have put, and the condom. And we put multiple holes in it so that any secretions can come out. And this mold is now put into the neovagina which is created. So remember one thing, that look at the ease with which we can put it. On it, we are putting the interseed. Means I don't want the addition of the epithelium which is created and the mold. So interseed is put, which is the addition barrier, and the ease with which we put the mold, and the speculums are removed. And we just have to suture. After 1 week, we remove it, and the neovagina which is formed is something which will be like well maintained, and it will be done. So finally, what I would think is these are the patients we had given through surrogacy babies for these patients through the vagina, or transabdominally oocytes are retrieved for these patients. And they have a normal sexual life, except the patient who underwent and the family and the doctor. Nobody will know it is created by us. Even the husbands do not know it is being created by a human unless they're married and they come for the neovagina formation. And epithelium and the normal orgasm, everything is normal, absolute normal sensation. So finally, therapeutic potential is huge. Can be used for Asherman, premature ovarian failure, fistulas, lichen sclerosis, polycystic syndrome, infertility, genitourinary syndrome of menopause. There are ongoing trials for endometriosis and for pelvic nerve injury, ovarian breast cancers, and also PROM. So for research plan for stem cells is either to form a scaffold or to put directly into the nerve injury, but we'll have to wait and see if nerve injury can be improved. Science is discovering the unknown, which you know, I know, but how much can we discover? Nobody knows, because it's something which keeps changing. What is right today can be wrong tomorrow. What is wrong tomorrow can still be right day after. Just like atorvastatins and everything, what happens? So can we be a part of the shape of the direction of this field is what I look at. So to conclude, regenerative medicine is a game changer. It can sometimes fully heal the damaged tissues and give them the solution and hope, especially in lichen sclerosis and neovagina formation. I can promise that 90 to 100% results can be given. Ovarian rejuvenation, we do have 80 to 90% results. Endometrial regeneration, it is about 70 to 80% results. So one thing we need to understand, solid organ transplants they've done decades ago, but advances in gynecology are just coming, and it is a single light of science, and to shine it anywhere is to shine it everywhere. So thank you, ISAR, thank you, Dr. Monica and everybody, Dhaval, Dr. Asha Bakshi, and everybody who has given me this opportunity.
Thank you so much, Manjula Madam. It was really enlightening, and in fact, it's indeed a opportunity and a privilege to chair your session.
Thank you, Dr.
I'm too junior to you, but still I'm mesmerized by the way you have got us all into the basics of the regenerative medicines and how far it can be applied in gynecology. Ma'am, I have one question. Like, we have talked about this endometrial regeneration with the use of this regenerative science, be it stem cell or PRP. And we have talked about there's around 70 to 80% of rejuvenation we have seen in the endometrium.
Yeah.
So is there some basic difference when there's a tubercular endometritis or if it's a chronic inflammatory one? So do you find a change in your studies when you do this PRP and stem cell in that?
Yes,
Can you just enlighten us?
In fact, that is what I said about of the results which we did not get neoangiogenesis. We have seen the individual, like we know how we have the keloid tendency and the hyperplastic scars. Each individual person will have a different tendency for the fibrosis to form. So if it is a type 3 Asherman's and tuberculosis where it is completely destroyed, where neoangiogenesis cannot be formed, there the outcomes are good or bad. So 75% result we got is because wherever we had this tuberculosis destroying to the level of type 3 Asherman's, yeah, that is where we did. Yeah, it made a huge difference, but in getting a 75% result is, I think, is very, very good.
Definitely, it's very huge. Thank you so much for that.
Dr. Manjula, if I can ask one thing.
Yes. As Ashish,
when you yeah, that's so nice of you. What is the time period when you're talking about the second time? 5 to 7.
Anytime it is 5th day to 7th day of the period is what we look at, because we do know that that is the time where the whole hormones and the activity, we have to synchronize. Synchronization is very important.
And what is the second time, if at all she wished to go for the second sitting, what are the criteria which has to go?
I wait for 6 months minimum before I can actually tell for them to go for second sitting. But majority of the cases, one sitting is enough, because over time we have evolved our techniques so much, Dr. Ashish. From 2019 till now, we keep fine-tuning our own technique, because when nobody is there to teach, we learn and we do it. Then we out time we say, this is not improving like this. Can we try like this? Can we try doing this? You know, that is how we change our own techniques in different way and come up. So now I get better results, much better.
Thank you. Thanks a lot.
Thank you so much. Thank you, Manjula ma'am.
Thank you.
And thank you, Manjula ma'am. That was like a touch of genius we have seen today in your work.
Yes.
And we wish you all the
Thank you.
success Maybe
Thank
the guidelines you set down have, benefit thousands of patients in India and, all over the world.
Thank you. Thank you.
All the best.
Thank you so much for a wonderful talk.
Thank
It
you,
is
Dr.
really, yes, it is really. I always remember your talk and your conclusion. It was very nice.
Thank you.
Good to see you, Manjula. It was very nice talk.
Hi, Dr. Asha. Thank you. I'm Archana. Thank you for having me.
It was really, really wonderful to listen to you again.
Thank you. Thank you.
Manjula, it's me, Asha.
Hi,
That was
Asha.
Archana.
I know.
Very nice talk.
Immediately corrected
Excellent.
myself. I was expecting one of you, and then suddenly I said it was Archana's voice. So again changed back to Archana, and then this thing. Okay. Thank
Hello,
you.
Dr. Asha Bakshi. How are
Hi.
you?
Hi.
I'm seeing you after a long time.
Thank you. Thank you.
Thank you, Asha ma'am and Monica ma'am, for giving us the opportunity to be here. Thank you, Manjula ma'am, once again.
Thank you for chairing the session so beautifully, Priya. And good evening, Archana ma'am.
Good evening. Good
Good
evening.
Evening,
Good evening, madam. And now I think we have got another very nice talk, which is the conclusion of the 4-talk session over here, after which we will move to the panel.
Thank you so much, ma'am, for enlightening us on such an interesting topic. Now for the next session, I invite Dr. Anita Rajoria, madam, and Dr. Jaya Kore Tulaskar, ma'am. Dr. Anita Rajoria, ma'am, presently she is President Delhi Gynae Forum Southwest. Madam is associated with many associations nationally as well as internationally. Madam is an active member of many FOXY societies, and she is past chairperson and endocrinology committee AOGD. Madam has been awarded many awards, and some of them are APJ Abdul Kalam Achievers Award, Wonder Foxian Award, and Inspiring Gynecologist North India Award. I welcome you, ma'am, for chairing the session.
Thank you for involving me. Thank you so much, Monica and the whole team.
Now I welcome Dr. Jaya Kore Tulaskar, ma'am. She was past secretary Society and vice president youth coordinator and MOX. She was past secretary, she was organizing secretary speaking international conference 2023. She has awarded with many gold medals, and her areas of interest is infertility in high-risk obstetric. We welcome you, ma'am. Now I invite chairpersons to introduce our guest speaker. Over to you, ma'am.
Thank you, Monica. Once again, thank you for involving me in this prestigious webinar of your wonderful series. We have been listening to very, very informative, and today's program has been also laid out very, very nicely. Thank you to Manjula also for that beautiful talk. Dr. Sangam Jha is going to deliver the next presentation. She is the additional professor, OBGYN, AIIMS, Patna. Executive member, ISOPAP, co-chairperson, Urogyne Committee, POX, Patna. She has publications in various national and international journals, reviewer for BMG case reports, pregnancy and childbirth series, etc. Invited speakers at so many conferences, presented many national and international papers, and many awards to her credit as undergraduate student also. She won Nirmala Saxena Award in 2020 for the best paper at East Zone RCOG 2021. She's been trained in minimally invasive surgery and advanced OBS ultrasound and Doppler. Her affiliations are many like FOXY, IAG, ISOPAP, and her special interests are endoscopy, urogyne, and pelvic reconstructive surgery. She's going to talk about laparoscopic management of cervicovaginal atresia. We all know is such a challenging clinical situation for all of us, although very rare, but it is a complex gynae situation. Some of the vaginal surgeons, they tend to do it vaginally, but it is more appropriate and recommended to do it by laparoscopic approach. And of course, the gynecologist or the laparoscopic surgeon has to be expert in that. And the trial given is to, connect the uterus to the vagina once the reconstruction is done. So we are really eager to listen to what Sangam has to tell us. Over to you, dear Dr. Sangam.
Ma'am, you're muted. Very good evening, ma'am. You're muted, ma'am.
Good evening. Thank you, Anita ma'am, for the kind introduction. Very good evening to all. I bring greetings from Patna. So at the outset, I would like to thank Dr. Monica Singh ma'am and her team for giving me this opportunity to speak on this platform. So, and it's my privilege to speak on this rare but challenging topic of cervicovaginal atresia. So are my slides are visible?
Yes, yes, they are visible. You can make it, yeah, full screen is there.
Okay, thank you. So my topic for today's session is laparoscopic management of cervicovaginal atresia. So in this session, I am going to cover little bit of the development of uterus and the vagina, how it present to us, and how to reach to the correct diagnosis and the management part. So as we all know, it's a very rare condition and reported prevalence is around 1 in 80,000 to around 1 in 1 lakh. So in 50% of the cases, it is associated with congenital vaginal aplasia. The most common presentation is usually primary amenorrhea along with the cyclical abdominal pain. Since decades, the classical management was hysterectomy with vaginoplasty. However, with increasing experience in reconstructive surgery, now the challenging case is being corrected by the newer techniques. So before we delve into the details of management, let us refresh our knowledge of anatomy and how the embryogenesis of the genital tract. So as we all know, the genital organs develops from two ducts, that is called Mullerian duct or paramesonephric duct. Are the ducts which shown in the pink color, which runs parallel and lateral to the mesonephric duct, which is going to form the urinary tract. So these run parallel and lateral. However, in the caudal part, it turns medially and joins to the tube from the other side. So fused part forms the uterus and the upper vagina. Vagina is formed from two parts, one from the Mullerian duct and the other from the urogenital sinus. As this fused Mullerian duct touches the lining of urogenital sinus, two solid sinovaginal bulb outgrows towards this uterovaginal canal, and these grows cranially and thus increases the distance between the uterus and the vagina. So this process starts at around 9 weeks and gets completed by 5 months. At 5 months, this solid vagina will gets cannulated, and the vaginal opening and the vaginal duct can be seen on the ultrasound. So vagina has double origin, upper 1/3 from the Mullerian part and the lower 2/3 from the sinovaginal bulb. So any difficulty or if there is an inappropriate fusion of the Mullerian duct, or there is a defect in the dissolution of the septum, that will lead to Mullerian anomaly. However, the exact etiological factors are not known. However, the following causes has been implicated in the defective development of Mullerian duct. One of them is the inappropriate production of Mullerian inhibiting substance in the female embryonic gonads. Second, it could be due to regional absence or deficiency of estrogen receptor in the lower Mullerian duct structures. Arrest of Mullerian duct development by a teratogenic agent, or if there is a mesenchymal inductive defect. Some cases can be due to sporadic gene mutations also. So ESRI has given a classification of this Mullerian anomaly in 2013, and it has broadly classified them as a uterine anomaly, cervical anomalies, and the vaginal anomaly. Uterine anomalies have been classified ranging from 0 to 6 categories, where the 0 is the normal one and the 5 is the aplastic uterus. U6 they have kept for the unclassified malformation. Coming to the cervical anomaly, so it ranges from 0 to 4, where 0 is given for the normal cervix, and if there is a aplasia, it falls into the category 4. And same for the vagina, 0 to for the normal vagina, and complete aplasia has been given as the V4 category. So cervicovaginal atresia falls under C4 and V4. So another classification has been given by some author of the cervicovaginal atresia. So it can be either cervical agenesis or cervical dysgenesis. Under cervical dysgenesis, cervical agenesis, where the cervix will be completely absent. In the cervical dysgenesis, it could be either absent cervical external obstruction, or the cervix will be atretic, or there could be a cord-like structure at the place of cervix. It can be associated with proximal segment atresia of the distal segment of the vagina, where the proximal segment may remain patent and can collect the menstrual blood, or it can be associated with the complete atresia of the vagina with the cervical aplasia. And the third category, it could be the upper portion of the vagina will be obliterated, lower third will be open, along with the cervical aplasia. Most common presentation is the amenorrhea, that is, in a patient usually comes with the complaint of inability to achieve menarche. And this primary amenorrhea is associated with abdominal pain. So to start with, they will have a cyclical abdominal pain, which will be progressive in nature, and gradually the chronic pain sets in. This pain, long-standing amenorrhea or obstructive Mullerian anomaly, there will be backflow of the menstrual blood into the peritoneal cavity, and that will lead to development of endometriosis. So pain can be there due to endometriosis also. They can also present with the voiding difficulty, because the enlarged uterus will press on the bladder and can present with the voiding difficulty. Sometimes patient, if presents early, they present with the backache also. So the most common modality, or we can say the first modality used for the diagnosis of such presentation, is the ultrasound. On transabdominal ultrasound, one can see the deformed uterine cavity. As you can appreciate in this picture, you can appreciate the internal os, but however, the external os is missing, and there is a balloon-like dilatation of the lower part of the uterus, and the cervix cannot be delineated. So the diagnosis is confirmed by MRI, and this is a gold standard for confirming the diagnosis of Mullerian anomaly. So MRI will show a distended endometrial cavity, as you can see this on the sagittal plane of the T2 image. This endometrial cavity is filled with the hemorrhagic fluid suggestive of hematometra. The lower, that is internal cervical os, is seen as the slight constriction. However, the external ectocervix is not seen, which is shown by the blue arrow. So that shows the absence of cervix, absence of vagina, with the dilated uterine cavity with the cervical canal. So the classical management for the decades was hysterectomy and vaginoplasty. However, with the growing experience of reconstructive surgery as well as ART, the hope for infertility for such challenging cases have been increasing. Thus, conservative management for the cervicovaginal atresia have been recently encouraged. So what is the goal of our conservative surgery? First is the relief of obstructive symptoms. The patient should get relief of her cyclical abdominal pain. Then achievement of satisfactory sexual function, that you should make an adequate vaginal length. And third is the preservation of uterus for future fertility. So I'm going to show you this video, and this is a case history of this girl. She was a 14-year-old female presented with the primary amenorrhea with the progressive cyclical abdominal pain. And she also noticed abdominal lump for the last 2 to 3 months. USG has confirmed deformed uterus with endometrial collection, having low level of internal echoes. MRI confirmed the diagnosis of cervicovaginal atresia. So the salient step for this procedure is the salient step for this is the first we perform the vaginoplasty from the vaginal end, that is a MEC vaginoplasty. The laparoscopic steps are: first, mobilize the bladder. Incision over the apex of the vagina, that is on the dome of the vagina, we make a colpotomy. Then second, incision over the distal part of the uterus and placing a catheter from the vaginal end into the uterus and then suturing the vagina with the uterus. So these all steps will be shown in this video. From the vaginal end, a H-sepid incision was made in the suburethral region, and with the help of blind and sharp dissection, a space has been created between rectum and the bladder. So approximately 7 to 8 centimeters of space has been created vaginally. On putting a laparoscope, you can appreciate a big hematometra with the signs of endometriosis due to retrograde menstrual blood flow. Has been incised. So push the bladder down. That the UV fold of peritoneum is being excised and bladder is being pushed down. So the first step is to mobilize the bladder. Bladder was pushed with the help of sharp and blood dissection. Adequate mobilization of bladder is important to prevent its injury. Bladder has been pushed further down. The lower limit of the vagina, this pushing of the bladder should be till you reach the vagina. So with the help of traction and counter traction, we can remain in a correct plane, and that reduces the bleeding also. So slowly we have completed the bladder dissection. A sponge on holder has been pushed by an assistant through blind ending vagina, and the bladder dissection has been completed. Now a stay suture has been taken in the lowermost part that helps in keeping the uterus retroverted. Now a hysterectomy has been done to drain out the collection. Almost 500 ml of collection has been drained out. Now, adequate colpotomy has been performed. As the sponge and holder is visible, and that completes the colpotomy. Now, incision has been made on the lower part of the uterus. To find out the lower extent of the endometrial cavity. The two incisions have been joined together for the adequate hysterectomy. And that shows the lower extent of the endometrial cavity. Now this anastomosis is being performed. The first suture is being taken from outer to inner in the vaginal flap, and then from inner to outer and the uterine flap, so that the knot remains outside the endometrial cavity. Second suture is being taken in the same fashion on the lateral side. From outer to inner side of the vagina, and then again from the inner to outer in the uterine flap. A Malicot catheter is being placed inside the uterine cavity, and that will act as a stent between two cavities. One more lateral suture has been taken. Hysterectomy is being closed with 1O Vicryl in a continuous manner. Final enter stitch has been taken in a quadrangular fashion. Needle passes from outer to inner side in the uterine flap, then inner to outer side in the vaginal flap, and again from outer to inner side in the vaginal flap. And finally comes out from inner to outer side in the uterine flap. And that completes the anastomosis. The remaining hysterectomy has been closed with 1O Vicryl. And this is the final picture. Small amount of endometriosis has been noted in the posterior compartment. The Surgisel has been placed on the raw surface of the uterus. Hysteroscopy was performed after 6 weeks, which demonstrate anastomotic site and normal endometrial cavity. So purposefully, I have kept the video slow so that each and every step can be clear to the viewers. Post-operative care is very important in such patients. We keep intrauterine catheter for 6 weeks, and vaginal mold, the first vaginal mold we apply is of made up of this sponge, and wrap on it. We wrap the enter seat and keep it for 7 days. Then the next for next 6 months, we make this mold of the dental cake, and the patient is asked to wear it continuously for the first 2 months, and then for during night time for the 6 months. After removal of the intrauterine catheter at 6 weeks, we normally perform hysteroscopy to look for the anastomosis, whether it is functional or not. Then follow-up is must to assure that there is no re-stenosis of the canal. So we call the patient at 2 months, 4 months, 6 months, and then 12 months. And at each follow-up, we take a history, whether she is menstruating normally, whether the blood, so menstrual blood has not decreased in amount, whether it's not associated with dysmenorrhea or something. Then we examine for the vaginal length. Sometimes the patient, if she's not wearing mole properly as advised, then she can develop re-stenosis. Sometimes this cervical canal also gets, this anastomotic site also gets stenosed, and patient then presents with again with the amenorrhea. So this patient, she is at 11 months follow-up, and patient is having regular menses with the patent vaginal length of approximately 8 centimeters. So what are the complications that can arise? So one is, as we are keeping the foreign body inside for the 6 weeks, so endometritis can occur. It can lead to pelvic inflammatory disease. Patient can have persistent pelvic pain, or during surgery, there can be bowel or bladder injury. So re-obstruction and stenosis can develop, which may require second surgery. So fertility outcome, there is one study by Mikos T. et al. Who has reviewed 249 cases of cervical malformation, which were managed by different techniques of conservative surgery. And they have shown that around 228 patients out of this 249 achieved menstruation. So regarding fertility, 30 pregnancies were reported, 17 of the 155 patients with the cervical agenesis and 13 of 171 patients with the cervical obstruction. So the fertility outcome is also encouraging. So to summarize my talk, the cervicovaginal atresia is a rare entity. Most common presentation is a primary amenorrhea with progressive cyclical pain. MRI is the cornerstone for making accurate diagnosis. Timely diagnosis and appropriate treatment can prevent its sequelae and preserve uterus. Thank you.
Oh, wonderful presentation, Sangamji. Beautiful video. And it was a marvelous surgery we were able to see today. It is important and imperative that the patient undergoes adequate urological assessment, because the congenital anomalies of uterus, cervix, and vagina are usually associated with urological problems also. So it is very important that you rule out associated urogenital anomalies. Only
Right.
then we should proceed ahead.
Yeah.
And you did not use anything at the time of surgery as graft for vaginal this thing, no?
Yeah, that is not shown in the video, ma'am. But we, after performing vaginoplasty, we put a mold made up of this sponge over the syringe, and over this sponge we apply interseed, and that is put in the vagina.
Okay. So means if only there is vaginal atresia, there are so many papers using other things. Initially, they used to use amnion grafts, then skin grafts can be used. But the patient is all right menstruating. I think it is a
she's all right.
great
But
success.
ma'am, we have experience of using interseed for last 5 years, and it has given an excellent result.
Good. Thank you so much, Dr. Sangam. Anita ma'am, we are a little short of time because
Jaya
the
wants
panel-
to say, and if Jaya wants to say, add anything.
Yes.
It
Jaya,
was
please.
excellent
give us
and
the
very,
conclusion.
yes, ma'am. It was excellent and very lucid presentation. You
Thank
covered everything, ma'am, from embryology to case discussion to beauty management and beautiful visual presentation. I must congratulate you for that. And I would like to also thank the organizers, Dr. Monica ma'am and her team, for inviting me for this webinar.
Thank you, Dr. Jaya. Thank you for accepting the invite in the first phone call. I'm so honored to have you, and thank you for your comments. Sangam, you were just marvelous.
Thank
And
you, ma'am.
Sangam and I,
Thanks for
Varanasi, we decided on this. So Sangam, you're going to be here in perfection again and again for sure. And Dr. Neetu, before you start the panel, please be sure to introduce the panelists just one line at a time, because we are very short of time now. Thank you so much, all speakers.
Thank you,
Thank
ma'am.
you, Sangam ma'am.
Thank you, ma'am. Thank you.
final session, that is the panel discussion on fertility enhancing hysteroscopy. For this panel discussion, the moderator, we have Kalyan B. Barmade sir. He is currently Vice President IAGE, and Dr. Dhaval A. Bakshi. He is Joint Treasurer, MP Chapter of IAGE. And as an expert for this panel discussion, we have Dr. Ajay Haldar sir. He is Professor OBGY Department at AIIMS Bhopal. Dr. Kalyan B. Barmade sir is currently Vice President IAGE and Secretary IAGE 2023-24. He has a very dynamic and active participation and has a very strong CV. He is Executive Managing Council member of.
It's okay, ma'am. It's okay, ma'am. Next, please.
We welcome you, sir, to this panel discussion
Thank you,
and looking forward for a very interactive panel discussion. Our next moderator is Dr. Dhaval A. Bakshi. He is SRA certified reproductive endoscopic surgeon and has won many awards in paper presentation and video presentation. We welcome you, Dr. Dhaval Bakshi, for this interactive panel discussion. And as an expert, we have Dr. Ajay Haldar sir, Professor, Department of OBGYN, AIIMS Bhopal. And we hope a very interactive sessions with panelists and are very fruitful outcomes from you as an expert, sir.
Thank you,
As an panelist, we have Dr. Anupama Sethi Arora ma'am. She is presently President of Sonipat OBGYN Society and Director of Tulip Hospital. We welcome you, ma'am, to this panel discussion. Our next panelist is none other than Dr. Archana Baser ma'am. She is Vice President FOXY 2020, Organizing Secretary AICOG 2021, Fellow Representative AICC RCOG West Zone, and Imaging Science Committee Chair SAFO. She is also a Guinness World Record holder for removal of largest uterine tumor. We welcome you, ma'am, to this panel discussion and looking forward for your inputs. Our next panelist is Dr. Bharti Singh ma'am. She is currently Associate Professor in the Department of OBGY, AIIMS Bhopal, and she is also a very dynamic personality. We welcome you, ma'am, to this panel discussion. Our next panelist is Dr. Brijbala Tiwari, ma'am. Due to her some family reasons, she could not be joining this panel discussion.
Please skip.
Our next panelist is Dr. Jyotinath Modi, ma'am. She is Professor, Department of OBGYN, AIIMS Bhopal, and she held executive post at Bhopal OBGYN Society. We welcome you, ma'am, to this panel discussion. Our next panelist is Dr. Nisha Kapoor, ma'am. She is Chairperson, Haryana Chapter of IAGE and Vice President, Haryana Association of OBGY. We welcome you, ma'am, to this panel discussion and really looking forward to hear from you. Our next panelist is Dr. Rujuta Fuke. She would not be joining us for some personal reason. Next panelist, please, Dr. Shatabdi De, ma'am. She is a consultant fertility specialist at Nova IVF Siliguri and convener of PAC FOXY. We welcome you, ma'am, to this panel discussion.
Good evening, everyone.
Good evening, ma'am. Our next panelist is Dr. Shushma Nigam, ma'am. She is a very senior gynecologist at government service in Bhopal and has a vast experience in obstetrics and gynae. We welcome you, ma'am, to this panel discussion and would like to hear pearls of wisdom from you, ma'am. Our next panelist is Dr. Suyesha Kanijao. She is an IVF expert, obstetrician and gynecologist and cosmetic gynecologist at Angel's Hope Hospital, Saket, New Delhi. And she has won many awards. We welcome you, ma'am, to this panel discussion. Our next panelist, last but not the least, young and dynamic Dr. Yukti Bharadwaj. She is a dynamic wizard and youngest of all. She is affiliated with many bodies. We welcome you, Dr. Yukti, and would like to hear from you.
Welcome, Dr. Kalyan sir and Dr. Dhaval Bakshi sir.
As a panelist. And now over to Kalyan Barmade sir and Dr. Dhaval.
Good evening, everybody. Very glad to be here with everyone. Uterine abnormalities like polyp, submucous leiomyoma, intrauterine adhesions, chronic endometritis, and congenital anomalies have been reported in around 21 to 47% of the patients. The most common is endometrial polyps, uterine septums, Asherman syndrome, and hysteroscopy plays a big role in treating all these conditions. So we are here with cases which are going to come to you in daily practice. So I request Dr. Dawal to share the screen, please.
Very good evening to everyone. I hope we have a nice panel discussion. We have Kalyan. I'm blessed to have Kalyan sir as a very experienced moderator and a star panel with a lot of stalwarts in it, and we'll get to discuss a lot of cases. So we've already done the introduction of all the guests and as well. So I think since we're running late, we'll jump up directly to the first case. So the first case, just as Kalyan sir said, that is one of the most common scenarios that we will encounter, and which is an endometrial polyp. So just to go through the history, so this is a case of a 32-year-old lady who's a case of a primary subfertility since 1 year. She's complained of heavy menstrual bleeding. She's been married for 6 years, and ultrasound suggests a bulky uterus with an endometrial polyp of 3 into 3 centimeters. Both the ovaries are fine. The antral follicle count seems to be normal. Her husband's semen analysis was done, and it was 12 million. So, yeah. So my first question will go to Dr. Archana Basair. And the question is that how will you manage this patient? So what is the plan for this patient?
Thank you very much, Dhawal, for putting up such a very interesting and a very common case, which I think is a very common in infertility practice or even to a routine gynec. I think what is important is you have already mentioned that she has husband semen analysis and all done. We have a very strong forte ultrasonography. So we'll do our sonography and look for the, like you have mentioned that she has a polyp already. So we will look at the blood supply of the polyp as well. And accordingly, we'll plan whether a hysteroscopy for sure, if she already hasn't had any history of hysteroscopy, we will be planning a hysteroscopy. And since it's a 1 year she has been trying for pregnancy, it means before she has come to us, she must have visited some few more places for infertility. By the time patient comes, it's usually they have consulted a couple of more places, and they are now like at a verge where they want that something more to be done. So I would subject her for a hysteroscopy and polypectomy. And your next question to answer, do all polyp in infertile women needs to be removed? Answer to this is very straightforward, that it depends on the duration of the fertility and it is which visit she has. If it is her first visit to you and she has never had any ultrasonography or any procedure before, then yes, you can observe her, measure the size of the polyp. If it is less than 2 centimeter, you can observe, and then maybe it takes in the next menstrual cycle, it may automatically regress, or maybe in the next cycle. So you can give a time of 8 weeks to her rather than subjecting to polypectomy. This is my answer.
So I think Madam has given quite a lot of insight. Kalyan sir, would you like to add anything to this?
Only thing is, according to the AAGL practice guidelines, EVS provides reliable information for the detection of endometrial polyps and should be the only investigation of the choice. The color Doppler is going to add to diagnosis of endometrial polyp, that is level B evidence. So the rightly said by Madam, we should go ahead with the hysteroscopy surgery.
Yeah, and what ma'am said that was absolutely perfect, that 20% of endometrial polyps may spontaneously regress over a period of 8 weeks. So depending upon the size of the lesion, usually the ones which are less than 10 millimeter in size will spontaneously regress, but this one was slightly larger in size. So we've posted her for a polypectomy.
First step in a hysteroscopic polypectomy is the same with
Yeah. So now the next question goes to one of the most high-tech persons who I know is Dr. Anupama Sethi. And so, madam, what is your preferred tool for a hysteroscopic polypectomy? There are so many toys, and I'm sure that you have all of them in your OP. So, ma'am, which one do you like the most?
I like the shaver the most. Obviously, because it removes the stock as well. Whether it is a sessile polyp or if you have a polyp, it's a big polyp, it is naturally removed easily with the help of the shaver. So I prefer shaver, but it depends upon what you are used to. Like everybody has got scissors in their hysteroscope set. So people usually use scissor, and that's it. And and some people also use resectoscope also for this, especially the adeno. Yeah.
Okay, so in clinical routine practice, it's very difficult to have a setup like Dr. Anupama. So better to use either a grasper or a scissors, cold knife is the best for this. Only as per Dr. Anupama, those polyps which are dancing polyps or big polyps which are there in the cavity where base cannot be found, where instruments like shavers are helpful. You want to add anything, Dr. Shatabdi?
Yeah, good evening, everyone. Very happy to be here amongst all of you stalwarts. As ma'am said, shaver would be the best option. But again, whatever that we are used to in the setting, I practice in Siliguri. So we don't have a lot of high-tech instruments over here. So use of the shaver, as I have only seen in videos and in various presentations, we are very used to the scissors over here. So we use a scissor and a grasper. It's as simple as that. We will cut it off with a scissor and remove it with a grasper. In my practice over here, that is the one that I use the most.
Everyone does that only. There are 4-5 shavers in the whole country. So don't worry, you are doing the right job.
I would say that obviously I used this scissor for last, I've been doing hysteroscopy for past 16-17 years. And in my previous years, I've used scissors and grasper only. That is the usual practice we had. And in few patients, we used to use that needle electrode also, so that they can pinpoint the stock. Okay, that's what I do.
Yeah. And I think sometimes using the needle electrode and slicing the polyp into pieces, so that removal becomes a little bit easier, also might help in some really large ones where, then because with the scissors, many a times we've seen that we can, disconnect the base, but sometimes extracting it might become a little bit difficult. And in not all cases can we dilate the cervix that much, especially in although the panel is for infertility, but in older women, sometimes when the cervixes are a little flush with the vagina, so dilating those cervixes are a little bit difficult. So maybe in those cases, if you use a little bit of an electrode, just to slice the polyps sometimes, so then that works as well. But definitely, I think usually in patients with infertility, we want to preserve the endometrium as much and, avoid any thermal injuries. So maybe we can prefer a mechanical source like a scissors, forceps, or the shaver, maybe, yeah.
Can I add one point here?
Yes,
ma'am.
Yeah, it's just that, regarding the retrieval, of course, a polyp of this big size of 3 centimeter becomes a challenge to retrieve if the cervix is tight, especially. So such polyps, they can be bisected or trisected before finally detaching it from the base. So you can remove it in 3 pieces right from the beginning. So don't detach it, because once it gets detached, it will keep dancing in the cavity. And then, it becomes a challenge to retrieve. So you can bisect the polyp or even make it into 3 longitudinal pieces before finally detaching it from the base. That helps.
Sir, one more thing
Dhaval, may I ask a question?
Yeah. Does the tool use has any impact on recurrence of the polyp, or just a technique by the surgeon?
Just the what?
Tool used has any impact on the recurrence of the polyp? Like sometimes the polyp recur again.
Electrosurgery can lead to adhesions later. So that is one thing. Maybe not.
Dr. Manisha, it is important to go at the base and cut the base. That is important. Okay. Those which are vascular polyps may recur if you are not done it completely or only you are just grabs the polyp and remove it. But otherwise, if you cut the base properly, then there are very less chances. Those patients who are undergoing IVF cycles or stimulation hormonal treatment, there are chances of a recurrence of the polyps. That to be less than 1 centimeter should be left away.
Also, the polyps which are detected during the stimulation cycle can be left as such because they are due to the drugs which are there. So they can be left. If they are less than 2 centimeters, then definitely we are not touching them.
Yes, Dr. Yukti, those we on day 1, if there are no polyp, and day 6, day 7, you find a 1 or 1.5 centimeter polyp, you can leave it away and can do a transfer. But here is the again role Dr. Anupama using. If you find that you have missed the polyp on day 1 and it's a big polyp like 2 to 2.5 centimeter in the stimulation cycle also, you can use a shaver and remove it because it causes less trauma to the endometrium and you can do the transfer in the same cycle if there is a less trauma. So that is another advantage to Dr. Anupama's shavers.
But sir, that depends on what date you find the polyp.
Yeah, that's what I'm saying. If you are done a day 2 scan, then it's very unlikely that you are going to miss it. But those which are polyps which are less than 1 centimeter be left. But those polyps which are more, then you can use such devices so that there is very less endometrial trauma.
Yeah, but then it said like if you just found it 5 days before your pickup or your transfer, would you take it out and do a transfer? So then pregnancies have not come up. The studies say that.
Yes,
but
that's
so
what.
Even practically, if you talk about it, if you find a polyp and you're taking out the same cycle, would you give a transfer? I mean, studies do say that if it's 5 days, 5 to 9 days, more than 9 days, but
see, firstly, those polyps which are less than 1 centimeter, I won't touch them.
Yeah.
And I have a shaver, so I use it without any trauma to the endometrial cavity. Then I am very sure that I have not damaged anything. And you have to observe on day 7, day 8, day 9, whether there is any spotting or any bleeding. And depending on the vascularity pattern, you are going to decide whether you want to do an endometrial transfer in the same cycle or not.
Agreed, sir.
Yes, Dhaval?
Yes, sir.
Ask very good question. Do you send all polyps for histopathology?
Yes, I send
Yes.
all.
Yes.
Any tissue taken out from the body should be sent for the biopsy.
We have to rule out atypia or carcinoma in these polyps. So they should be definitely sent.
Yeah. So, yeah, I think the whole consensus is that whatever you remove, although polyps are the lesions which have the lowest malignant potential, but still, if you look at it, if you look at the evidence, around 2% have hyperplasia and 1% might have endometrial carcinoma. And especially in patients with polycystic ovaries, we have seen 2 patients with secondary infertility and polyps turning out to be endometrial carcinoma. So please do not miss out on sending these for histopathology. Many a times we think, chota sa polyp hai, kya karna bhej ke? But just to stress on this point, this is why I added this question.
You have done a very good hysteroscopic polypectomy. When you are going to allow this patient to have pregnancy? Dr. Sueksha, you can.
So 2 months post polypectomy, because the studies have shown that if it's more than 3 months or 4 months, the chances of recurrence are there. So minimum of even next month, you can ask the patient to try for pregnancy, but studies have shown that the healing will take 2 months.
Yeah, because uterine cavity is healed within 6 weeks to 2 months, but postoperatively, but there is insufficient evidence to advocate specific length of time before women should conceive. But rightly said, six weeks is a time where you can wait.
Should not delay it for more than 6 months.
Right.
Yeah. So I think now we'll go to the second case. We've covered, I think, quite a lot regarding polyps. So the next case, polyps, was actually.
Ajay, you want to add something as an expert? We are finishing the first.
Sir, I would differ from using the word expert. I will, rather be the observer here. And the one thing which is, there's jokes apart. One thing I wanted to ask, whether, although it is not the question here, probably because we are talking about infertile patients, what happened to vascular RPOCs, which may look like polyps? So what special precaution do we take when we are dealing with vascular RPOCs? Just because the question has arrived regarding polyps and the device which has to be used to deal with polyps.
I think, Dr. Ajay, if I may answer this,
Yes.
first of all, I mean, you would, what are you saying that differentiate between polyp and RPOC, or if there's a RPOC, proven RPOC you are removing?
Yes, yes. You've proven RPOC. The question is more related to what device, what special precautions
Okay.
we have to take when we are removing RPOCs,
Okay.
vascular RPOCs in a hysteroscopy.
We are going to come afterwards, but I like to
Okay,
say
okay.
we need to rule out AV malformation in so many of the patients. That is
Yes,
one.
yes.
Secondly, you have to be really cautious enough whenever you are doing the surgeries or hysteroscopic surgeries for RPOCs. The part will be covered in the next few questions.
Okay.
So
okay.
this lady has
Fine.
36-year-old woman, known case of hypothyroidism with history of recurrent pregnancy loss with secondary infertility, came with complaint of heavy menstrual bleeding since last 7 days, with passage of small clots, married since 2 years. 3D ultrasound has showed 15 millimeter of ET with RPOC in mid cavity and fundus of 1.5 into 0.8 centimeter. There is a query subseptate uterus with bilateral PCOD. So now, what is which one you would like to tackle first? That is septum or RPOCs? This is a general question. Dr. Nisha can take this.
Yes, I think RPOC takes the precedent over septum, but why not do it at the same go? Because if you are, able to remove the RPOC comfortably with scissor without damaging endometrium, and it's not looking like an infected cavity, then you can deal with the septum at the same go. That's what is my take, that we can do it at the same go.
And so when you're doing it at the same go, do you want to remove the RPOC first, or do you want to correct the septum and then touch the
Remove the RPOC first so that we have a clear view of the septum and the ostia, so that we can, take care of the landmarks, anatomical landmarks when we are doing the septum.
Okay, ma'am, but sometimes are you worried about bleeding when you touch the RPOC?
I was coming to that, Dhaval. I think I would remove the septum first, because the picture you are showing, it's quite clearly seen here. So I would attempt the septum first and then remove the RPOC and come out, because RPOC may bleed and then your field might get disturbed.
I slightly differ here, ma'am, Dr. Archana, ma'am, because firstly, it is important to remove these RPOC which are there since long time. Maybe we can do a septum in the second setting. That is not required. So many times septum may not cause infertility and she has conceived. So maybe it's a doubtful, but I will go for a RPOC removal.
But this particular patient has pregnancy loss also, no? There is recurrent pregnancy loss. So I think septum in this case does need to be addressed.
Sir, I did one patient in which the RPOC was on the septum. Means it was like avascular. So I removed the RPOC and then I removed the septum in the same sitting. But usually these RPOC don't have vascularity. If they are vascular the thing and the patient is bleeding for 20 days or 30 days, so we have to remove the RPOC in first go. Then we can look for a septum, maybe in the second sitting.
RPOC can also cause infertility. So if she's been trying to conceive, if you remove the RPOC, it is said that the spontaneous pregnancy rate is up to 80% within the first 6 months of the RPOC removal. So definitely the RPOC should be removed first, and then we can think about the subseptate uterus, whether we have to do it we have to incise it at the same go or do it later, but the RPOC has to be removed first.
So consensus is RPOC first, followed by septum, because that is more dire required surgery because she's bleeding for last 7 days. Dr. Dhaval, you can continue.
So I think we can just continue with Dr. Ajay's question now. That what special precautions would you take while dealing with vascular RPOCs, the ones in which are labeled as AV malformations? So what would you like to do? That would Nisha, madam, would you like to take this question?
Yeah. See, if it's a vascular RPOC, one thing is that we can devascularize, before starting with the procedure. Like I can sort of give vasopressin in intracervical to reduce the intraoperative bleeding. That is one thing which I would like to do. Second, I would rather use resectoscope, bipolar resectoscope, taking care that I don't damage the surrounding endometrium, but I do a clean cut resection, with the resectoscope rather than venturing it with the scissor. So if it is vascular, I'll rather use a bipolar resectoscope. And then during, we can use misoprostol. If the patient is bleeding, we can put misoprostol per rectum. But generally it is not required. But vasopressin, of course, is a precautionary thing one can do if it is already reported that, it is a vascular RPOC. Vasopressin does help.
Sir, if you're suspecting an AV malformation, then it is very important to involve an interventional radiologist. So maybe if it is a malformation, that maybe the patient requires a uterine artery embolization instead of a hysteroscopy.
Has somebody got experience of methotrexate? We do sometime in AV malformation, give MTX beforehand.
It would be useful to have the catheter placed, I think, the interventional radiology, and when we are encountering a heavy bleeding, then we can go for embolization. So that's one precaution which we can take if we really think it's a big AV malformation.
Yeah, I think the points that have been covered are quite clear, but just to share my own personal experience, because fortunately I've tackled quite a lot of such cases. So I think the points that Nisha madam said are absolutely perfect. That because most patients, like I think all the patients that we had, we could just manage them by intracervical installation of vasopressin, because the AV malformation, we have to realize, is because of that placental connection that is persistent from the retained product of conception. So that is the actual causative reason for the AV malformation. So just by removing that, half of your job is done. But the only thing that accompanies it is torrential blood loss, and there is quite a lot of bleeding. But in all of the cases that we've had, we just injected vasopressin into the cervix and gave a little bit of compression, and it worked quite well, because all facilities will not have these
unless we
and embolization. So I think maybe just to simplify.
Dhaval, yeah, I just want to add, you can put a Foley's catheter inside if there is too much of bleeding.
Yes,
along with bimanual thing.
Massage, yeah.
Yeah.
So I always love to keep things simple. So I think just by doing all our simple measures, that what we do to tackle PPH, I think we can just use all of our resources on that line, and you can manage most of these 99.9%, I would say.
Exactly. I will agree with you, Dr. Dhaval, because so many AV malformations refer to us being a tertiary center, but I haven't had any patient where I had to do any other intervention. I have been regularly following just, some precautionary measures like injecting vasopressin, and never had to get an embolization done. Most of the AV malformations reported are actually retained products of conception, and they are not actually AV malformations. That is what is my personal experience of the cases referred to me.
Also, it is very important to send the vascular RPOC for histopathology to rule out gestational trophoblastic disease.
Exactly. That is important, yes. And also to follow it with beta HCG.
Beta HCG may be so many times chronic things, so they can be negative also. So
many times I've seen that in patients with RPOCs, the beta HCG is already negative. So the active dividing tissue, once it gets over, so then the beta HCG level may fall.
The histopathology report is self-sufficient to say.
Yes, ma'am.
Yeah.
So very rightly discuss about the RPOCs and AV malformation. It is very important that whenever you are suspecting a large AVM, it's always better to do it in a tertiary center. Then you can do this transcervical injection of vasopressin and go ahead with the procedure. If there is a torrential bleeding, then you can always go for intrarenal ligation. Next slide, yeah. Dr. Dhaval.
Yeah. So the next case is a 28-year-old lady with primary infertility. She's been married for 2 years. husband semen analysis is normal. On a 3D ultrasound, the uterus is normal size, but the septum is reaching up to the internal os. So now my question is to Dr. Ruchita. Is there a benefit in resecting septums in infertile women? I think maybe there might be. Yeah. Does anyone else want to take the question?
Sir, if it is a case of unexplained infertility or there is history of RPL, recurrent abortions, infertility, IVF failures, then there is definitely indication for septum removal. Plus, this is reaching up to the os, so this septum has to be removed.
Dr. Suyesha, do you want to add something to this? You'll have to unmute yourself.
Yeah, so I was just saying that in this case, it's not the septum which is the cause of infertility. We need to look out the other causes also. Septum basically causes recurrent pregnancy losses. But since it's reaching up to the os, we need to consider taking it out. We need to consider doing a septal resection in this case, because if she turns out to be pregnant and then she miscarriages, then that's going to be difficult.
So now let's just put a twist to the story. And now supposed to say that now you're planning an IVF for her. So pre-IVF, would you do a septum resection or not before the embryo transfer?
I will do it. I will.
Yes,
definitely do it.
I will
It's a
do it.
complete septum. I will definitely remove it.
Definitely.
So if it is a partial septum, you won't remove, Dr. Suyesha?
So it depends on the size of the septum. If it's
Length, not size. Yeah.
sorry, the length of the septum. If it's not more than 10 mm, I will not remove it. And if there's no history of any recurrent pregnancy losses.
I think up to 5 centimeter we can keep it. If it's more than that, we should go ahead and remove it.
How much centimeter?
1.5 centimeters.
Yeah, it is a differentiating point. So everybody's everywhere. The literature doesn't say that you have to remove the septum. Ideally, it should be a incision of the septum is the right word, not removal, because we don't cut the tissue. So Dr. Archana, madam, what is your take home in routine practice? Just leave this literature part. What you do whenever you see a septum?
Oh, first of all, Kalyan, as you have already mentioned that the septum is reaching up to the cervix. Whatever, first.
No, not this patient. Generally, ma'am, in your
Generally,
practice.
okay, just general. First is a very good ultrasonography, right?
3D ultrasound.
See like a 3D ultrasound, endometrial volume and everything. You have to see the size of the septum. And you cannot have just one rule for all, depending on the patient's history, like duration of fertility, history of recurrent miscarriage. Is there any other contributing factor to her infertility? Then you decide. As already being mentioned, if the depth of the septum is greater than 15 millimeter, then you are definitely going to remove it. So depending on the size and the history, we do cut the septum. So I think septum needs to be cut, because suppose if you are doing an IVF or infertility, first of all, it will interfere with your embryo transfer, and second, it does have a risk of having miscarriage even in the second trimester, or maybe you might end up into the premature delivery. So I think septum, if identified and you are skilled and patient needs it, you have to do the septum dissection of the septum, and we do it.
Anybody differs from this?
Well, there are some studies which say that only if there is recurrent IVF failure, we should do the septum. But
Or
then
recurrent
I think,
pregnancy loss. Or
yeah,
IVF.
recurrent pregnancy loss or IVF failures. But I think if you put in a hysteroscope and you see a septum, the septum has to go before taking up a costly procedure like IVF. I think it's none of a big deal actually to resect a small septum. So I would go ahead and resect it if the scope is already in.
Though meta-analysis doesn't say this, but there are so many prospective control trial studies have shown that women with unexplained infertility, hysteroscopic resection of septum improves the pregnancy rate and live birth. Before IVF, incomplete septum removal improves pregnancy rate, live birth. In cases of RPL, hysteroscopic metroplasty improves the live birth in both groups, and subfertility with past history of miscarriage, hysteroscopic metroplasty improves the live birth rate. But only thing is hysteroscopic metroplasty with residual septum of less than 1 centimeter doesn't adversely affect reproductive outcomes. So the length matters. So wherever you find that length is less than 1.5, you can leave it back. But those patients with history of RPL, you need to tackle them whenever you are putting a hysteroscope. That is a general guideline as per the clinical condition or clinicians. Dr. Dhaval, you want to add something?
Yeah. No, I think everyone has covered that quite beautifully. So I think now we'll shift on to, now we've put the scope in. Now we've all decided that we have to do a hysteroscope. So Dr. Jyoti Nath ma'am, what will be your choice of energy when you do a septum resection? So would you like to, go for cold scissors? You want to use a bipolar needle? You want to use a resectoscope? So ma'am, what is your tool of choice?
Okay, so first choice for a thin septum would be at least try with the scissors. And failing which, it could be a needle. Overuse of energy, if we are trying to we have fertility in mind, so I generally would err on cold sources than on energy sources. That would be then, and complication wise also, it is much better to go for cold sources first. But yes, for thicker adhesions, I think needle does a beautiful job. If you use a needle, you do a little bit and a little bit goes on its own. So before taking the next shot of the needle, at least wait for it to recede a little, and you will need to use energy much less. That is my take on the thing.
Just a follow-up question. So there was a concept in between that since this septum is of a fibrotic tissue and it is not a healthy tissue. So do you want to excise the septum in any case?
No, I don't think so. I don't subscribe to that view. Natural tissue should be preserved. If it recedes, it's going to be resorbed. If you're using a cold source, nature will have a way of covering those areas which have retracted. So these situations are so difficult that you don't have randomized trials for a follow-up. What if I did this in a thick? So these are like soft evidences. And a lot of it is individualized. Once you put the scope in, you have to be ready for all. But then you take the decision right then sometimes. Of course, if you have a very thick septum, you know you're going to use the energy source. Even there, I would first begin with the scissors and see. Sometimes you can snip a little bit on one side and then a little on the other, and it does recede. So, but yes, fibrotic septum, coming back to your question, I don't think I will resect it.
It is said that the septal tissue has a retractile property. So if you give an incision on the septum, on the midpoint of the septum, the tissue on either side will start retracting automatically.
Yeah, that's exactly what I said, Yukti, that when you take a cut with the needle, wait for it to retract before you take the second shot at it. So that becomes patience during the surgery.
Very rightly said, Dr. Jyoti ma'am. I'd like to add 90% of the time septums are fibrotic, but sometimes there are muscular tissues. What Dr. Dhaval was talking was about removal of this muscular tissue which is hanging on both sides. It is maybe worthwhile if in 5 to 10% were more of a muscular part that can be removed. Otherwise, incision is always better. Resection is a misnomer we use. It's not resection, it's an incision of the septum. Resection is for muscular part where it has to be removed and sent for the histopathology.
Oh, that incision is just a way of helping the septum go back to its place.
Its original place. Right. So what is the end point? Dr. Shatabdi, you want to add something?
Yeah. As rightly discussed, the end point would be when we can see both the ostia in a single panoramic view very comfortably, and we see some of normal healthy tissue at the fundus, where we decide that now it's time that the fibrous part is over. We are seeing both the ostia and we should stop at that time.
Okay. Anybody wants to add something? End point?
And what I'd like to ask in particular is, Would you like to overcorrect the septum or undercorrect the
No,
septum?
undercorrect.
It's always
Undercorrect.
undercorrect.
To undercorrect it.
It's always undercorrect.
So what we have to remember is we don't have to create an umbrella inside,
Yes.
and maybe a little bit of an undercorrection is much better because because of the actual shape of the uterus. So the ostia will be placed slightly higher than the fundus in general. So a lot of people sometimes they become a little overzealous and then create a small umbrella umbrella-like cavity. So that we have to always be careful that you have to either just optimally correct it or a little bit of undercorrection is also fine, because as we've all seen that even if there is a less than 10 mm of a residual septum, so usually there is it doesn't affect the fertility. So that is there. And another thing that what I'd like to add is just in case these thick muscular septums, sometimes they do tend to bleed. So sometimes maybe you would like to bring out your old traditional Collins knife in those cases, because even with a bipolar needle, so the bipolar needle, the tricky thing is that the needle and the white part ahead of the needle, all of it has to be in contact with the septum. Then only it cuts properly. Otherwise, the control that you get is a little bit difficult. So sometimes earlier I was a big fan of the bipolar needle, but now with the small miniature resectoscopes that are there, I'd actually like to put in a small Collins knife rather than the bipolar needle. So the next question I'd like to ask Dr. Anupama Sethi is that in case the septum extends to the cervix, so will you do you cut the cervical septum? Do you let it be? And if you do not cut it, so then how do you manage cutting the remaining part of the septum?
See, I cut it. Normally, I cut it. And normally, I cut it with the scissors so that we can go inside, we can get inside the cavity. And like I normally do it with just a plain scissors inserted into the cervix. And then that scissors actually creates the space. And then we go inside and then everything is seen and then we cut further. This is my done. This is my done. But then, some people do add, like they start retrograde and then they come ahead like using a Collins knife. But that is the way I do it. I'm telling you that.
Dr. Nisha, you cut the cervix, ma'am?
No, because there are more chances of incompetent cervix, if you cut the cervical part. So you can, put Foley's catheter, pediatric Foley's catheter on one side and start cutting in the middle and then complete it, down and up. But leave the cervical part, that is what is ideal.
Okay, Dr. Archana, ma'am, what is your view? You want to cut?
I normally cut the cervix septum as well, because as Anupama said, that it gives you a better view. I don't have experience of doing it with the pediatric Foley's catheter, so I'm of the school of thought that you should cut the cervical septum, and we do it with the scissors.
So, what is your experience about the cervical incompetence in the future? Because we are worried about that part, Dr. Nisha and myself. We have never cut the cervix. Yeah.
Yes, your concern is very genuine about the cervical incompetence, but I don't think there are any studies on a large number of women with the cervical septum being cut and not cut, and what was the outcome. This is our fear, which is genuine, but this is not like being studied. So if there is going to be cervical incompetence, yes, it can happen. We will talk to the patient because we already know the extent of the septum beforehand by our good ultrasonography. We can always talk to them that yes, it needs to be removed, and in future if there is an incompetence, either we have to deal it with the cervical cerclage or the pessaries and something, but if it is removed, it's better.
Sir, the ASRM guidelines say that the chances of cervical insufficiency are not increased if the cervical septum is removed. Plus, removing the cervical septum, the procedure can be done in a faster manner, and the fluid deficit will also be less. So that's what the guidelines are saying.
Yeah, because we are doing by putting either pediatric Foley's on the opposite side or even a dilator. which can be movable so that you know where to cut. So a metal dilator can be kept on the opposite side. Time taken
Ultrasound
is
guidance also helps, when you are doing it from the middle.
right. So there is a always debate going on whether to cut the cervix or not to cut cervix. In my limited study of around 45 cases, I have never cut the cervix. So maybe next time we can have a study,
I have
another
done it
study about the same.
approximately in 28 cases, and I've cut the septum as well,
Right.
cervix. But usually I write it down that there is a chance of cervical incontinence. So we are very cautious during her pregnancy. If there is any shortening, then we'll put a cervical encircler there and then.
Yes, Dr. Dhaval, next slide, please.
So the next question is for Dr. Suyesha. So if the patient is planned for an embryo transfer, when will you schedule the transfer after a septum resection?
2 months. After 2 months. Yeah.
So what are the medications you give after removal of this septum?
So nothing, I mean, there's nothing required to be given after this. You can just, when you're preparing a patient for FET cycle, then you need to give the patient estrogen, progesterone, whatever you give support.
So anybody is using pediatric Foleys for complete septum so that it should not have adhesions?
Sir, if it is a thick septum, generally in the end there is some bit of bleeding. So it's always better to use pediatric Foleys for about 3 days, and you can give progesterone like estrogen and progesterone side by side. So after 3 days you can remove the Foleys. There's no harm. But that is for the very thick septums. For smaller
Thick or complete septums.
Yeah.
So these are the cases where I use estrogen and progesterone for 2 cycles, followed by the next either IUI or IVF cycles.
Yeah, I've also followed the same as what Kalyan sir just said. So
Agree.
So now the next case is a 47-year-old lady with primary infertility. She underwent a laparoscopy earlier and was seen to have a lot of adhesions and was diagnosed to have Fitzhugh-Curtis syndrome. She has hypomenorrhea. She's a known diabetic, known hypertensive, and is hypothyroid. She's been married for a long time, 22 years. She's had 3 failed IUIs, 2 failed IVFs, and just as I said, that one diagnostic hysteroscopy and laparoscopy where radiolysis was done. On an ultrasound, the uterus was small and the endometrium is thin. So we're suspecting Asherman syndrome for this patient. And but what will be the next step for this patient? So Dr. Archana Basir, ma'am, if you would like to take this.
Dhaval, it's a really, really very complex situation. Here you have a perimenopausal woman.
That's why I asked you this question.
With a very small uterus, with a multiple medical problems. Really, she should be counseled before for really, I mean, yes, as a surgeon, as a thing, it's okay. Like, but if you have gun, doesn't mean that you have to use it. You have to counsel. I'm not saying dissuade her, but you have to really, really warn her about all the problems which she can have with the procedure and with the pregnancy per se. Because you are, like she's getting pushed to the not so good health-wise and for the baby's sake. So I think I'm just first going to, like, you have to do all her medical comorbidities control, then you have to investigate her for all those point of view, and then you have to sit down, write everything on the papers that you have done a counseling till the morbidity and further, because it's a really, really high risk. But then suppose if you want to work on her Asherman's and you are doing her hysteroscopy, I would simultaneously do the laparoscopy, because in a small uterus, when you are doing any instrumentation, your chances of perforation are high. And apart from that, putting the fluid for distension may cause her, ARDS or anything. So you have to be prepared for all sorts of problems which can be there with hysteroscopy. Do hysteroscopy along with the laparoscopy, and then you do the adhesiolysis. And beforehand, I'm sure you must have done your ultrasonography and everything to see that how you're going to do, and maybe she should be counseled for your PRP also, PRP in the future.
Yeah.
Sir, can we rule out tuberculosis in this case? because she's had Fitzhugh-Curtis syndrome. She has had diagnostic hysterolaparoscopy with adhesiolysis previously. Now she is having hypomenorrhea with a small uterus. So we should definitely keep tuberculosis also in mind. In this.
Yeah, certainly tuberculosis and the perimenopause that can cause hypomenorrhea. AMH level, I'm sure. must
At
have done
47,
before.
what do we expect for the ovarian reserve also? Like,
Yeah.
doing so much for her. And there could be like even PRP and stem cell can be helpful after doing adhesiolysis in these cases.
So everybody is going to use a laparoscope from abdomen, or somebody used to like to use ultrasound guided hysteroscopic adhesiolysis?
Laparoscopic patient
Dr.
laparoscopic.
Nisha ma'am, what is your view in institutes?
Well, in this particular case, I'll be happier putting a laparoscope. Because this is not a simple case, no? This is already a case where she has been operated earlier also. And the uterus is small and the walls, the myometrial thinning might be there because of perimenopausal age group also. So I'll be rather happy putting in a laparoscope.
And one more thing, sorry, Kalyan, it's always easy to say ultrasound guided, but when with the, like you're putting ultrasound and thing, it's not very easy intraoperative to assess like how depth you are going. So what I found that though we talk about it and it is helpful, but it may not be in such cases very helpful when the uterus is so small.
No, because why I was saying this, she must have undergone one laparoscopy prior, because Dhaval has diagnosed Fitzhugh-Curtis syndrome. So
Yeah, but
try
she
to
can
put
go
one
for
small scope, because so many times there are so many adhesions, so many tuberculous abdomen and all. That's what I believe, that you should be very careful. You can tell the patient to do that. I'm going to do in 1 or 2 or maybe 3 settings. And anytime you feel you are near to the fundus, 1.5 centimeter is the cutoff of that myometrium, then you can just stop the procedure. This is my belief.
But sir, this is a very complicated case, so it's better we do it under vision.
Right.
Of laparoscopy rather than ultrasound.
Right.
No, but at the same time, 47 and medically fit or not fit and added. So if you look at risk benefit, there may be a case in point in going for an
aggressive effort,
ultrasound
we
guided.
are going to make on this.
Yeah, because all said and done, a simplistic USG will also let you see whether you are in the cavity or touching the wall. That is essentially what you're looking at. And though we've always done under laparoscopy guidance, that has been the convention. When you talk of adhesiolysis, you automatically think laparoscopy guided. Thinking about USG guided is new, but at the same time, why we didn't think about it?
Ideally, these are the cases where you should either do in an office hysteroscopy setup, because wherever you are going to touch the myometrium, patient is going to have some pain. What is your views, Dr. Dhaval, about this?
Yeah, usually what I don't do this in an office setup, because the reason being is because I know that it's going to be a slightly longer procedure than normal standard hysteroscopy, like a polypectomy or a septum resection. So your point is absolutely valid, that actually, I actually now my mind has started working in those lines, and maybe I might want to post one of these patients in the office setting. But because similar to, when we do a septum resection, so once you reach the muscular part, so then the patient starts feeling it. But usually I just do it under standard GA. In most cases, I don't put in a laparoscope because I think hysteroscopic guidance is good enough. If you have somebody who's trained to show you where you are, because I think so, just by saying doing it under ultrasound guidance is not enough until and unless you have a good radiologist or a good sonographer with you who can actually guide you, because this is just like, you're going in blind. So the person doing the ultrasound is actually like like the Labrador dogs with which the blind people have along with them, and they are the ones who are guiding them the whole time. Why I would refrain from putting in a laparoscope in these patients is because, suppose, yes, definitely if she does have genital tuberculosis, maybe she also has a lot of bowel adhesions as well at the same time. So even putting a laparoscope in these patients is more like dangerous actually, because then those added morbidities of all those other injuries might also come into play. So usually ultrasound guidance good enough. And I think if you just go small, slow and steady, just take a few snips at a time. Most of the times you can just get into the right place. The
Millimeter by
moment of
millimeter.
loss is when you can see the normal ostia.
Yeah,
So I-
and according to the Minimally Invasive Journal of Gynecology, there is no evidence that hysteroscopic adhesivolysis guided by external imaging techniques, either laparoscopy or ultrasonography, there can be improving clinical outcome. But such approach is used judiciously in selected patient may benefit that you can prevent the perforation.
Yeah.
That is
And
what I
also one more thing that I would like to add is that always have a vaginoscopic approach in these patients, because many a times you will have adhesions right at the internal os, and visualizing that small tiny opening at the internal os can make a huge difference whether you're gonna go into the right plane or into the wrong plane, because it is very easy to create a false cavity subendometrally. In these patients, you can cut up all the muscle tissue open. And similar to this case, which we've just shown, is that once you just negotiate that with your scissors and get into the right place, half of your work is done, because you've actually entered the cavity per se. So I think so that is just one last point that I would like to impress upon regarding the surgical technique.
Also, I think in such cases, you must put misoprostol preoperatively. That also helps to loosen the cervix and any adhesions over there.
Yeah, anything that can facilitate your scope to go in easily, and also to use a thin scope, because a lot of people, you have a 4 millimeter telescope, but I think this is one place where the 2.9 or the 1.9 scopes definitely have an advantage
Very,
over
very
4
important.
millimeter scope.
As far as possible, 1.9 or 2.9. Secondly, always use scissors. So many times we were using bipolar prior, and if perforation occurs, then you have to go for a repeat laparoscopy, find out whether there is any trauma to the bowel. And also, even a scissor perforation, you might not do anything and just forget this patient. Observe for 48 hours, there is no need to put laparoscope also.
So I think, yes, so we've covered this, how will you prevent perforation? So I think a lot of people have different opinions about what is the commonest site of perforation. And there are a lot of, the literature will say something, but in your personal experience, although, sir, you are the moderator, but I'll ask this question to you. That in your experience, what is the commonest site of perforation?
Always, wherever there are adhesions on the lateral side, I have perforated twice, thrice, because you are doing the part on the central, that is the thickest part, but towards the lateral part, I have perforated it. What is your view?
Yeah, I think so, sir. Similar with me, because most of the time when I've perforated 2 or 3 patients, and usually it is in the lateral part towards the ostia, near the ostia, because that is where
the myometrium is thinnest
as well.
And
So,
you always want to create that virtual 3 triangular cavity,
Yeah.
In the center, you have a lot of part to be seen, but laterally, you don't know where is the ostia. So many times the perforation occurs at the thinnest part.
So I think just a quick go through that. If the perforation occurs, first is how will you identify it, and second, how will you manage it? Dr. Shatabdi, do you want to take this one? Just a quick 2 lines.
Yeah, as Dr. Kalyan said, if a perforation occurs, if it's happened with a needle and we have identified it and it's not very big, there is not excessive bleeding at the site of perforation. From the site of perforation, we would just like to observe her for 48 hours. But if it's a bigger perforation, or if it's happened with a cautery, we would have to put her through a laparoscope and then find out whether other intestinal organs or any other organ have been damaged in that case.
And in case the perforation occurs, the first site that what I feel is that there is a loss of distension pressure.
Yes.
So before you can see through the uterus,
Use some
momentum first.
Yeah.
So momentum, and plus the cavity will also start shrinking. You will ask your assistants to keep on increasing the pressure, but the distension will not be there. So I think so that is one of the earliest signs of perforation. So
And
that is
please,
what one
please
should
don't overcorrect it. Keep it undercorrected. At the end, I will show one video where a patient was operated in one of the IAG workshops, and she came to me at 7 months with I'll show you the diagnosis later. Yeah.
Here, I would like to make one comment, Dr. Dhaval, that if, the perforation has happened with a monopolar instrument, then the injury could be, not only at the sigmoid, it could be at a very distant place. So it's very important to, look at the whole of the intestine in the pelvis, all the loops sitting there, because it can be at a distant site. So one should avoid monopolar as far as possible. Try using scissor. And if at all, I think bipolar or laser nowadays, so many people are using. I don't have a personal experience, but if anybody can give any comment on use of laser in Asherman.
Yeah.
Yeah, we have Dr. Anuja Kulkarni from my place where I have done 2-3 cases with her. And she uses YAG laser, ND YAG laser since last 10 years. She has a good volume of around 200 cases by time. She's doing adenolysis, septum, everything with the lasers. And it's a good instrument. You have to be away 0.5 centimeter from the lesion. And it is like a video game once you start doing it. But it is available in multidisciplinary approach where a urologist is there in your hospital. Good tool to use.
Even
but one Nisha ma'am, always hysteroscopic Asherman, always use scissors.
Yes.
No
Yes.
lasers also.
Yes, yes. Agree with you fully.
So I think just the take-home message is that always use scissors for Ashermans. In case a perforation occurs with scissors, you can still, just keep a watch at the patient. But if any current, current is used, if you're using an energy source, always put in a laparoscope and screen the whole bowel. So always involve one of your friends in case you see that something is there. Always recognize the injury early and manage it rather than just, just to feel that, arre kuch nahi hua hoga and just, to leave things by chance. So I think we cannot leave anything to chance and always take a consent. I think, this is the role where consent plays a major role, is that if you're doing an Asherman or a difficult operative hysteroscopy, always take a consent for an SOS emergency laparoscopy if needed.
Also, I think in the consent, Dr. Dhaval, it's very important to talk about recurrence to such patients, no? That 2 out of 3, in such cases where you have severe Asherman, they might recur and a relook hysteroscopy is, might be required. So that is also an
Dr.
important
Nisha,
part of
I
the
also
consent.
to them about the getting back the menses. That point also has to be talked to them first. Secondly, recurrence. Thirdly, pregnancy, second trimester losses, ectopic pregnancy,
Accreta.
IUGR, placenta accreta. All these is a procedure-specific consent, and we are happy to share IIG has got all these procedure-specific consent on their website. Please go through.
So, Dr. Jyotinath, could you just take us through the strategies that you employ for preventing adhesion reformation?
Okay, so the simplest is to put an IUCD or use a Foley. So a mechanical barrier probably works the best, but in combination with a hormonal support, like during this time, sorry?
IUCD without copper.
IUCD.
No, IUD.
No, yeah. So the newer devices which are available, not IUCD, not conduit, but the newer devices basically mechanically put the walls apart and use the hormone to cover the surfaces. Those are the 2 principles for keeping it. So combination of mechanical plus hormonal is what is best. 2 to 3 cycles of hormonal and estrogen. Estrogen alone has been tried, but estrogen progesterone combination in a continuous method for 60 days is what I have used earlier. And mechanically, Foley's is good for a temporary phase and remove it when the hormone has taken over.
Hyaluronic acid can also be used to prevent
Yes, those are new things
adhesions.
which can be used now. So yes.
Yeah, but do we get hyaluronic acid gel?
Not in India.
It's easier to use a hormonal.
Only one thing I like to add, Dhaval, here, that we are doing after 7 days, we just put this pediatric Foley's catheter, inflate it, and just come out. That we do every 7 days, twice.
That is
So
a very good way of, yes, that's a midway solution between retaining, because we always wonder how long to keep and how long is good enough. Will hormone have taken over? But that's a very good one. Keep reminding the uterus to keep apart.
And it prevents the adhesions, ma'am. That is another
Yes.
thing.
No, that's
And
that's a very good. That's a new learning today.
So, sir, you're just putting it and you're taking it out.
out, yeah, for maybe say 5 to 10 seconds only.
Does
Initially, those filthy
anybody
adhesions.
have any
Dr.
experience
Suresha,
of
those filthy
using
adhesions will
PRP in such
broken.
cases? PRP or stem cell for Asherman?
Not in the first
Sitting, but
if
yeah.
you have done a second surgery or third surgery, then
Yes.
intramyometrium, we do all 4 corners, we put this, ma'am.
So you were saying something?
So till how many days you follow this protocol of putting repeated Foley's catheter?
Putting?
Foley's catheter? For how
Yeah,
many days?
initially first, we have to keep it for 3 to 5 days. Once you have done that, then after 7 days, so that adhesions are flimsy, so that you don't want, or you want to break those adhesions, we put it every 7 days twice.
So I think that is a substitute for the second look hysteroscopy.
Yeah, that's what I was about to say. Then do you do a second look hysteroscopy or
Yes,
not?
but still you always do a second look scopy in cases where you have done a extensive job of Asherman's adhesiolysis. It's mandatory to do a second look scopy after 6 weeks time.
Yes.
Maybe
6
4
weeks
weeks
to 2
also.
months, yeah.
4 weeks also.
Just says 2 weeks to 2 months.
2 to 3 months.
Another small practical tip is that whenever you're putting a pediatric Foley's, just inflate the balloon outside the uterus, see till where the balloon is going and cut off the tip of the balloon.
Yes,
Because
it's
what will
always
happen,
cut off.
otherwise if the tip is there intact, so then the balloon will get inflated in the isthmic region and not in the fundal region.
And
So
patient will
basically
also have
want to-
pain also. Yeah, right.
Yeah. So that is what you want to do. And nowadays, I think the PB guy or a few of our local guys have also got that triangular balloon stent is also available now. Earlier, it was marketed by Cook, but
Now Dr. Sushma Deshmukh has got this new, which is available with PB, 3,000 rupees. It's very good.
So that is also there. And plus the added advantage is that it doesn't dangle outside the vagina of the patient. So that awkwardness that the patients might feel that with the Foley's inside, that is not there. And also the shape is more physiological, more anatomical. So, you know, if it will go to all the corners. So I think so maybe. And regarding the pain, I'm not so sure, but it seems to be a good this thing.
What is the
Also-
name of the device, Dr. Dhawan?
Ma'am, it's an intrauterine balloon catheter. You can ask the PB guy. The PB guy will have it.
Okay.
Yeah. So now we all have established that there definitely is a look of a second look hysteroscopy in extensive cases. But the question is that when will you plan it?
2 to 3 months.
Any time between 2 weeks to 2 months.
6 weeks.
Any
4
time.
weeks to actually 4 weeks to 8 weeks.
I think not after 6 weeks. It should be well before 6 weeks, because the more you wait, the denser will be the adhesions.
Exactly.
And you will end up doing, you know, a lot of work again. So it should not be delayed too long, I feel.
4 to 6 weeks.
As early as 15 days.
2
Can
weeks.
do it.
Yeah.
Yes,
2 weeks.
as early as 15 days can also.
New learning.
Yeah, so I think what we just have to impress upon is that the earlier the better, because then, you know, while the adhesions are reforming and they're thin and weak, you can go ahead, lyse them. So you have less work to do. So it's more comfortable. And this is what the evidence is also saying, that an early second look hysteroscopy is better than a delayed one. So I think any other points do we want to discuss regarding Asherman's, or I think we've covered everything?
I think covered everything. Only PRP also everybody.
PRP and stem cells.
PRP I've reserved for the last case actually. That's why. So I think the next case is that of a I do hope we are on time and we're not exceeding. So the chairperson.
Dr.
can-
Monica, what is 8:15? What is our time limit?
See, I have no time limit. So my studio is always ready for me, you know, 24 hours. So I have no
Another
time limit.
15 minutes will take, ma'am.
If the moderators want to give some important tips, they can take extra 10 minutes, I think. 10 minutes we wrap up, I think.
In next 15 minutes we'll wrap up. Yeah, 3 cases.
Right. So, Kalyan sir, anything for you, sir?
Thank you, ma'am.
So I just a quick now we'll just brush through the cases a little fast. So now the next case is that of a dysmorphic uterus. She's a 29-year-old woman with primary infertility, married for 5 years. husband semen analysis shows oligoasthenoteratozoospermia. She's underwent IVF and has had 2 failed embryo transfers. 3D TVS shows T-shaped uterus with a small cavity. So now, how will you manage this patient, and is there any role of a lateral metroplasty? Dr. Bharti Singh, do you want to take this question?
Yes, sir. Thank you, sir. So this type of uterus is the 3D TVS is very much important or specific to diagnose this type of uterus. And previously it was linked with in utero fetal exposure of DES, and it is also included in the latest classification also. And we should deal this type of patient with lateral metroplasty with the help of instruments like bipolar needle micro scissor. So we have a mini resectoscope like thing nowadays, and we can do it with micro scissors or with a small bipolar needle. So we should do a lateral
Yeah. So now
section of the but some studies they are not very clear evidence, but if in cases of recurrent implantation failure, recurrent IVF failure, we should go for the lateral metroplasty.
Yeah, so I think this is very important that lateral metroplasty is not for all patients with a T-shaped uterus. In case she has some poor obstetric history or recurrent implantation failures, maybe that is when you can consider this. So now, now that we've gone inside, what would you like to, how would you assess? First of all, is that how much has to be resected, and what is your instrument of choice? Dr. Yukti, do you want to take this one?
We should make sure that both the cornua, when we are seeing the panoramic view, both the cornua should be at the same level. So that should be our endpoint. And we should use cold scissors for lateral metroplasty, since this patient is trying to conceive.
And especially the lateral part is having the lowermost, lesser thickness. It is very thin as compared to the fundus. So it should be cut very few fibers should be cut with the help of micro scissor will be better.
Yeah. So is anyone
Bring
using
it from cranial to caudal, and you should always remember that the lateral is it's very thin, so you have to be very careful while dissecting it from top to bottom.
Also, I think ultrasound, is going to help us if we have done a good 3D ultrasound and we know the thickness of myometrium on the lateral side. Then we know how much, we can afford to cut. So that is another thing, I think. And then guidance by ultrasound during the procedure, that is again going to be helpful in some cases, in some difficult cases.
And does anyone like to use a Collins knife?
No. I don't
What were
recommend.
you saying? Do you want?
No, I was just saying because, as you're doing lateral metroplasty, the fibers are cut, those thick fibers, like those whitish fibers, which are actually the fibrosis in that area, they will get cut. And as soon as you find a pinkish color or bleeding, you just stop there. This is my, mainly that's how I go for it.
Yeah, because I think that's a good important point, because the lateral part is from where all the uterines are pumping in all the blood. So that is where although the muscle wall, the muscle thickness can be actually variable, because it will be thin in a normal uterus, but especially when it's a T-shaped uterus, it's a little bit thicker.
Yes,
It's a little bit thicker. So I think if we just aim towards the ostia and take the markers of that bleeding, I think that is, what will provide us a safety margin. Also, what is important is that you just start just a little bit beyond the internal os, because if you start, there is going to be a ring of fibrosis at the just beyond the internal os. The moment you open it, the uterus does open up, because many times you'll be struggling at the lateral areas, slightly above, higher, and when you come back down, you will still feel that you still cannot see the ostia. So sometimes just trimming that that ring at the internal os will help with performing an easy lateral metroplasty, and always look at the.
Yeah.
Yeah. So I think we've, does anybody want to add anything else apart from this for lateral metroplasties? Dr. Suyesha, do you want to chip in with something?
No, sir, I think that's fine.
Yeah, so answer. And last question is that when, in case you're, because for this lady, we want to do an embryo transfer. So when do you want to do the embryo transfer for this patient?
Again, preparation is very important. So give estrogen and progesterone for 1 to 2 cycles, and after 2 cycles, you can go ahead. And important is in all these cases, you have to know for the impedance flow. Color Doppler flow is very important in all this patient wherever you are doing a transfer, because Asherman, lateral metroplasty, whatever surgeries you are doing, you want endometrial receptivity to increase. That is what is the end point. So you need to do color Doppler flows prior to the transfer one cycle prior.
And I think we can counsel the patient that that you want to do a mock endometrial preparation, and just to see, you know, what protocol she's responding to the best, because she's had previous 2 failed cycles. So I think so that's it with that. Submucous fibroid, Dr. Zhao Ming has showed us quite a lot of techniques, but that was all stepping out of the box, because he's in some of them, he was stepping outside the cavity and going into the intramural fibroids as well. So, but standard, just for the standard teaching, we'll just go through this one quickly. So she's a 32-year-old woman coming with complaints of heavy menstrual bleeding leading to anemia. She's had a vaginal birth. 3D TVS shows her type 1 submucous fibroid, which is quite large. It's 4.3 into 3.6 centimeters and bulging into the uterine cavity. So now the question is,
how many of you really do these big fibroids cystoscopically? Dr. Nisha ma'am. Yeah, the whole you are doing, and I have seen the case also. Dr. Nisha ma'am, what is your views?
Yes, actually, if it is a fundal fibroid, I'll be more scared. But if it is an anterior or posterior wall fibroid, then I can venture onto it with the consent for 2 sittings, with the consent for need of laparoscopy at some point of time, if the patient is bleeding. So with all that consent, I can venture. But for a fundal and a lateral fibroid, I'll be more skeptical, you know, trying it histoscopically.
Dr. Anupama, you are using this Lassmer classification?
Yeah, sir. I've been using this Lassmer classification. I do up to 4 centimeters, not more than that. I normally don't do more than 4 centimeters fibroids. And obviously, I do the fibroids which are on fundus as well, because these days I've started using this shavers. I'm using shavers for this fibroids. And believe me, if your the myoma is soft, degenerated, it goes up very nicely with the shaver. But otherwise, we have to use resectoscope. There's no choice other than resectoscope for myoma removal, for sure.
So you are using this dual technique where half of the part is done by
half of the like we start with a shaver. If it is being done fast, then we use shaver till the end. Otherwise, we convert it in between, and then we use that 9 mm same resectoscope for bipolar resectoscope for just removing the fibroid.
Dr. Barbade, I think these are the cases where there is definite role of GnRH agonist. You know, this patient is not infertile and there's no emergency to do it in this cycle. It's a borderline size, you know. So you can make it more amenable to histoscopic resection if you have given GnRH agonist.
Yes,
Yes,
I
very nice.
totally agree.
Agreed with me. Yeah.
Because she's not infertile, she's not in a hurry as such.
Yeah. So GnRH, Dr. Sushma Nigam, what is your choice of pre-operative treatment? Would you like to give GnRH analog? Would you like to give ulipristal?
Yes, I would like to give GnRH.
And for how long, ma'am? For how long would you like to give it, ma'am?
For 3 months.
So one single depot preparation of leuprolide 11.25. I think so. That is what you're doing now.
That should be enough.
Yeah. And but is it only GnRH, or you are flexible with ulipristal or mifepristone as well?
Can be used ulipristal and mifepristone.
Yeah. So just to go through, so now recent evidence is coming through that mifepristone actually is only reducing the symptoms of the fibroid, but the actual size of shrinkage of the fibroid is a little bit inferior when you compare it with ulipristal and GnRH analog. So maybe for the preoperative choice, maybe we can look at GnRH analogs as the gold standard, and as an alternative, something more physiologically friendly to the patient could be ulipristal. So that is there. So now Nisha ma'am, you've posted for surgery. So monopolar versus bipolar versus shaver. I think we've had a little bit of this discussion with Anupama ma'am, but just, when would you, do you ever use a monopolar now, or you've only shifted to bipolar? And so ma'am, what is your
see, bipolar became available later, no? We all have been using monopolar for years together before bipolar became available, right? And in large fibroids, I think you have to have a balance. Speed is also equally important, to prevent volume overload. And I personally feel that monopolar is more speedy as compared to bipolar. So for smaller fibroids, definitely bipolar, it is fine. But for bigger fibroid, speedier, thing, and if you've got enough experience of it, for years together, you've been using monopolar resectoscope, I don't think there's any harm in using monopolar. I find it more speedy as compared to bipolar.
Also,
and of course, as Dr. Anupama said, that if you have the leverage of using a combined modality, then of course, you can save, you can have less problems with fluid deficit and all. That initial part, you can do it with the resectoscope, and the buried part, later on part, the bedside, when you reach it, you can manage it with Moscillator.
Ma'am, what I would like to ask is, in your experience, do you have more bubbling with the bipolar, and is there more more gas generated with the bipolar compared to the monopolar?
Yes, with larger fibroids, I'm more comfortable and a cleaner view, with monopolar as compared to bipolar.
Yeah, also, I think so the glycine will give us a little bit of a better view because it's slightly more thicker than normal saline. So that blurring of the vision when bleeding occurs is a little bit less. So I think so maybe that is one of the rare situations where we would, like to go in and step in for this. So how will you identify what is the endpoint for resection? Dr. Yukti?
We try to get a clear cavity, the ostia being at the same level when we are seeing in the panoramic view. So yeah, it should not be an overzealous approach also. So we should be.
How will you identify that now the resection is done? Because especially when you're doing a type 0, definitely yes, you can just see the whole cavity. But if it is a type 1 fibroid, so then how will you know that when to stop? I think so Anupama ma'am was...
We can slightly decrease the fluid pressure. Also, they say if you do bimanual compression of the uterus, it can put this fibroid, which is type 1, can slightly, it will come into the cavity and we can identify that. So that is also one thing to do.
And the color of the fibers is the most important. It's a gray color for the fibroid. Once you have taken it out, it's the pinkish myometrium, which is, visible below.
Yeah. So I think that is one important take-home message, that you should look for the pinkish tissues, because once you see the pinkish tissues beyond that of the fibroid, so then that is where you've gone and resected the capsule as well. So, and that is the end point. So I think so, you have to keep that in mind. I think we've discussed choice of distension media, and pre-medication also already covered. Post-operative treatment is important, is that when will you allow the patient to conceive? So Dr. Ruchita, would you like to take this one? In your experience, how long do you advise, contraception for these patients, for submucous fibroids? I think Dr. Ruchita is not there. Dr. Shatabdi?
I usually give contraceptives for pills for around 3 months. 3 cycles I let pass, and then I would like to go ahead with further treatment for these patients.
Okay.
I think Dhaval, it's like quite arbitrary. Like the healing, what are you waiting for is that the healing is complete. So healing of the myometrium, like endometrium is a very fast, the organ where the blood supply and all will happen. It depends on, how long the patient's infertility has been there. So I would wait for only 8 weeks.
Yeah, I think it will also depend upon the depth
Type of
the
fibroid, I think that is also, no?
Yeah, because if it's a type 0, so then maybe because there is no myometrium left to heal. So I think so maybe those patients can be allowed to conceive the next cycle as well.
Next cycle
But
as
in case it's a little deeper, so then that is when we have to advise a little bit of
Exactly.
contraception.
3
So
months.
I think anything between
Again,
8 to 12 weeks should be fine. Archana ma'am,
yeah, I think it's like everyone's experience and how the size of fibroid and patient's age and everything will matter here. And like how long the infertility, where there's a rush, you're like running short of time. And I think there are so many factors which needs to be taken into account. You can't have a fixed rule.
Sugar करूँगे.
so now we were all discussing about thin endometrium and PRP and stem cells. So with the use of Asherman, so just to continue the same discussion a little bit, I think Dr. Manjula Anagani has given quite a thorough and detailed lecture about the use of PRP and stem cells. So this is another patient who's had persistently thin endometrium on various protocols and is tired and thinking of giving up on treatment. So would you advise in your practice, Dr. Suyesha, do you give stem cell therapy or PRPs to
Sir,
patients?
I do. I do give stem cell also, and I give PRP also. And particularly in this patient, we can definitely try for subendometrial PRP because we've tried making her lining and the lining has not been formed. So next cycle, we can do a hysteroscopy and we can insert hysteroscopically guided PRP in the subendometrial region. Like in all four corners, we can just put 1 cc of PRP.
Yeah, so always is it hysteroscopic injection, because some of these companies have also come out and said that you can just inject it like an IUI. So
you can do that if you're making the lining and the lining is thin. You can just insert it with the IUI cannula. You can put 1 cc inside. Like you can do
The
it
results of subendometrial are probably better.
much better.
Some people put the subendometrial injections on the 4 sides, and the left
that's 1 cc on 4 sides.
cc left. They put it like intrauterine in the cavity.
Yeah.
Dr. Dhaval, there are some contradictory studies coming and saying that it is leading to fibrosis and doing more harm than good, So we have to wait and see ultimately. It is all surrounded by, still controversy.
A lot of studies have come up that the results are really good. Even the personal experience.
I take a consent from the patient that it is a under research setting.
Because there's nothing to lose. It's an autologous thing. So you're not having any side effect.
Yes. Even I've had for my IVF patients, I have used, like in previous failures, I have used PRP and the results have been quite good.
Yeah. And there is a role of stem cell in cases of Asherman's where there's destruction of the basalis layer also. Then there is a role of putting stem cells along with PRP.
Yeah, so I think just
nicely putting the
PRP works well. I mean, within your ovum pickup needle, it can be really done nicely for all our hysteroscopic surgeon.
But you always have to remember that 1 cc will get wasted in that needle. So you have to prepare more sample and put it. And just put the beveled edge inside and in the slanting position. Like just slant it and put it.
What is important is, I think so, that it has to be delivered at the endomyometrial junction.
Yes.
So you have to go in a little bit and then, inject it in all the 4 walls.
All the 4 corners and just wait for a while so that it doesn't come back.
Come out.
That is there. One more practical tip is that whenever you are injecting it, many times that you see that if you've just attached the syringe directly to the oocyte pickup needle, you will get a backflow as soon as you withdraw the needle a little bit. So it's always important to put a 3-way stopcock, and as soon as you've injected, close the stopcock, remove it. Otherwise, what happens is, because of the hysteroscopic pressure that you have inside, there's some filling of the distension medium into your saline, into your PRP solution. So you will feel that you've injected 4 ml on all 4 walls, but you'll have 10 ml in your syringe still left. So just to avoid those so to let the
Well,
PRP actually go there.
yeah. I would like to add here what I've been trying to do, that I inject 1 cc in anterior wall or whatever wall you're doing, and then stop my inflow of hysteroscope for about 20 seconds.
Yeah,
And
yeah, ma'am, that has
again,
to be done.
so that that everything that remains inside. That is my thing.
Yeah. So a lot of people have advocated using a relatively lower pressure when you are doing this, and give time for the PRP to get a little bit distributed into and for it to be absorbed whenever you're injecting it. So what is very important is that it has to reach the endomyometral junction, and there I don't think that there is much of a role of injecting it into the just cavity. And there's a good study that I came across. So they compared intrauterine versus hysteroscopic injection, and they saw that the thickness was achieved with both methods. You could get the endometrial thickness even if you just instill it intrauterine, but in the cases where it was put into the endomyometral junction, they had a higher implantation rate and a clinical pregnancy rate. And I think so that is more important for us rather than just having the thickness. So always put it into the put it in hysteroscopically.
Dr. Dhaval, single sitting, multiple sitting, your comments.
Ma'am, I feel that it is still a very new technology. Usually the patients who will respond to one setting. I don't find I've put it in a few patients in 2 sittings, 3 sittings, but then I haven't seen them respond. And the ones in which we put it in multiple times. So usually the ones who will respond within 1 sitting.
You should counsel the patient about the prognosis and that she might need a surrogacy later.
Okay, thank you.
Yeah. We also have to always have to tell them that that this is a new thing. It may work, it may not work. Yeah. So I think so. We'll also always have to counsel them regarding non-benefit of the technique as well. So that is what is important. So coming across to I think maybe this is one of the last few cases. You just go through it quick. So this is a patient with secondary infertility. She's anxious to conceive, borderline AMH. She's had a vaginal delivery. Husband semen analysis is around 8 million. She doesn't want to wait because she's getting a little older. So she was being posted for IVF, and in a pre-IVF hysteroscopy, so was done. And when you go inside, so then you have this appearance of an irregular shedded endometrium and presence of small micro polyps. So and diagnosed to have endometritis. So are there any what are the signs and symptoms that you look for in a hysteroscopy for endometritis, especially in these patients? Anupama ma'am, would you like to comment?
Yeah, that is stromal edema, hyperemia, as well as micropolyps. These are the 3 proper signs and symptoms of chronic endometritis. And if it is very much red and there is a lot of hypervascularity, that also indicates acute endometritis. So normally, if you have an irregular endometrium wall is something very irregular, though it might be just post-menstrual, but after post-menstrual, the endometrium should be actually equal. So if it is like this kind of an endometrium in a normal patient of any stage of the cycle, it should be labeled as endometritis.
So would you like to send any diagnostic tests for these patients?
Yeah, usually I send
needs to be ruled out. Culture, you have to send
tuberculosis. Tuberculosis, of course, has to be ruled out.
culture, tuberculosis.
And culture, of course.
Total leukocyte count.
What is faint green?
Sample can be sent for a HNE staining for the counting of plasma cells, and if there is availability of immunohistochemistry, then maybe CD138 can be done.
So
Usually these things are not available to us. So we normally send it for histopathology as well as for TB PCR. My thing is that.
Gene expert as well?
So, ma'am, Gene Expert is just an added this thing with the rifampicin resistance. So, what we have been sending is this, instead of a TB PCR, we just send it for something called a DICE panel, in which other than tuberculosis, it looks for around 10 more entities, 10 more bacteria which are causing it, and it gives us quite a lot of things, because many a times we send our TB PCRs. Earlier, we used to see a lot of TB PCRs to turn out to be positive, but this I'm talking about maybe 10-15 years ago. But as soon as the technology got a little bit more refined, then the false positives came out to be less. But we're still perplexed at what to do with these patients. So nowadays, this new panel has come, in which they're doing PCR for other species as well, and you can pick up and then give directed antimicrobial therapy along with it.
Is it
I've
same as
never-
Alice?
Prefer it to
Alice says
CBNAT
Alice.
as well, the PCR?
This is called DICE from LifeCell. So LifeCell is doing it. So you just have to send it in saline the same way you do as a TB PCR, and it gives you all these other groups of.
How
microbes.
much is the cost?
Do you send for CBNAT or do you still prefer the PCR?
Ma'am, this is what we've been sending. So, ma'am, this is what
Not
we've
the
been sending
CBNAT?
for the past two years. Before that, we used to just send it TB PCR.
No,
Yeah,
I'm
I just
saying the
want to
It
know.
CBNAT
detects
versus the
tuberculosis
PCR.
also. It detects tuberculosis also.
Yeah.
But you are not doing it in every case, Dhaval, right? It is where you are
No.
suspecting
This is
endometritis.
suspected. This is when we're
Yeah,
suspecting it.
suspecting, then yes. Otherwise, routinely you like what we send TB PCR and endometrial histology.
Yeah.
These
So
are
this
the
is
two
when
things.
we're
This is
suspecting it.
Dhaval, where is it done? Where is
Done
it?
by LifeCell, as you said, and then this
And
available.
the cost?
It's not very expensive, I
Cost
think.
I'll have to find out. I also don't know.
Acha, means it's not very expensive, right?
No.
Not very
Not very
expensive.
expensive.
Not very
3,500. Cost is 3,500.
Oh, very
Cost-
nice.
the
Then we
cost-
can also go for it.
How is the sensitivity it is?
So we've sent around 100 samples of DICE, and so they've picked up quite a lot of interesting organisms. So, but the most common, apart from tuberculosis, has been ureaplasma. So ureaplasma is the most common one, and then depending upon that, then we do. But eventually, at the end of the day, the treatment is doxycycline and azithromycin.
Yeah, that's it. That's it.
So this is just allowing you to put a name to what is there. So what is the infection, rather than so this is about giving judicious antibiotics rather than just empirical therapy.
We can also add probiotics with these antibiotics.
Yeah, definitely probiotics. So but what we do is we add the probiotic after the antibiotic course is over, because otherwise पेट में probiotic डाला, antibiotic डाला, दोनों वहीं के वहीं पे खत्म कर दिया एक दूसरे को. So
I would like to make a comment here that, the pickup rate of, even you put all the combined tests of tuberculosis, the pickup rate is not too great.
Yeah,
So
yeah.
how many of us, with a shaggy endometrium, micropolyps and typical, picture, and you get some caseous, spots over there. Do some of us, are, convinced about putting such patients on AT-TIM empirically, particularly if laparoscopy also being done simultaneously and you are able to find, some tubercles over there. So I just want to know the opinion of the panelists, all the
Ma'am,
panelists.
in our setup, we are putting them on empirical ATT, but we're not the ones who prescribe it. So we send them to a chest physician, and they apparently, in our state, they have a criteria that if you have a strong clinical suspicion as well, so then you can start anti-tubercular therapy. So the strong clinical suspicion is backed by our
Dhaval, why you are sending to TB chest guy?
No,
Because
in
you are
our
the one.
state-
No, you are the one who has
ourselves.
diagnosed it. You are the one who has diagnosed it.
No,
and you
in
have
our
strong
state, no, in our state, we cannot
have to
prescribe
notify.
AKT.
Notify,
AKT has
I
to be
think we have to
prescribed by the
notify.
physician.
Has to be dispensed through a dot center only.
Oh, it's
No,
free
no,
of cost.
no, madam. Here I would like to differ, madam. Now the Nishchay portal is there, and Nishchay
Yeah.
Yojana, we did a whole perfection series. There are 4 criteria for tuberculosis diagnosis, and even if you get a confirmed confirmed a Cox-like picture on laparoscopy or hysteroscopy, you can start AKT. Just inform the authorities, madam.
Exactly. That is one of the criteria for
And we
starting
have to
ATT. That if all the
notify
other
the
tests are
patient.
negative, but
And
you have
now
a
the criteria
strong
has become very
suspicion on
relaxed.
hysterolapro, you can start ATT.
Yes,
Yes,
yes, you
agree
can
with
start.
that. In hospital-based setups like us, we have DOT center, so we work in collaboration with them. All we need to send them is if we find a clinical evidence, we just have to mention strong clinical suspicion, and then they always call up and ask what is the kind of suspicion, or we mention that there is laparoscopy evidence, or there is simultaneously the sample for CBNAT rather than the RT-PCR, which is a more expensive test. CBNAT is a much simpler test which can be sent. And
Right.
a second sample goes for AFB culture, which can keep coming later. You know, that takes much longer, but we do, when we take a sample, we do send for everything.
Yeah.
We hardly get an output on staining, but CBNATs really help with a very quick turnaround time, much safer, much quicker. And
Yes.
also the DOT center have the facilities, so simultaneously they are able to prescribe also.
Cost-effective.
So it's
CBNAT
a
is
sort of
payment-free.
linkage between the DOTS services and what we find clinically. So at least those can work very well.
And Dr. Jyoti, there is also the facility for imaging diagnosis. If there is strong
Agreed, yeah.
suspicion on the ultrasound, you get a retort-shaped hydrosalpinx. That also you can start AKT.
Yes,
That is also one of the,
what
you
they
know,
want is a clinician to commit that there is a strong clinical suspicion, and also to ensure, so once you're committing, the bigger part they're interested in, that the patient should not conceive and stop the ATT, or somebody should not prescribe it too lightly, because resistance is becoming a major issue now.
Yeah.
So, often what happens is when we start and patients conceive and patients stop and then we don't look back, that is the part they are most angry with gynecologists about. So,
the guidelines
So,
formed by Professor J.B.
I think,
Sharma.
Dr. Dhaval,
And,
I would like to
anybody
say
who
here, the
wants to
picture
go
which
to
you
them-
showed, you know, even if urea plasma is positive, you know, that test might be misleading us, that one thing is positive, but then the endometritis picture is very typical of tubercular. So,
Yeah, but
you know,
ma'am, in the panel we sent, it also has it also screens for tuberculosis as well.
okay.
Yeah, and ma'am, luckily, fortunately, we in our city don't find that much tuberculosis in our practice.
All
So
right.
over the past many years, hardly very few cases now are picking up. Earlier, we used to get
For us, it is
lots
very
of them.
common in our part of the
Country,
state.
exactly.
It's quite
I
common.
think
Yeah,
the
it's
more
very
we are
common.
looking, the more we are finding, because there was a time when we stopped thinking and we forgot about tuberculosis. We used to think about a lot in the years I trained, and then there was a gap for some decades where people stopped thinking about tuberculosis as a cause, and I think it is, we should look actively for it. As regards looking for other organisms, does it make a treatment difference if you're anyways treating the
Doxycycline
yes,
has to
yes,
be given, yeah.
doxycycline, the combination, if you're giving, that is presumptive. We give it to the patients who are following up with complaints of discharge, and we find some soft evidence and we give them. So diagnosing urea plasma, chlamydia, it doesn't have a application in terms of treatment. We are just
a
increasing the
lot of
cost of
patients,
diagnosis.
a lot of patients are skeptical about receiving empirical antibiotic therapy, and they kind of
Right.
question us that why are you putting them? Another thing is doxycycline has its own side effects. So that is
Once
why
you
also
see a
we,
clinical
What
evidence,
about,
but if you're seeing endometritis, you can treat endometritis. The only specific endometritis which needs a different treatment is tuberculosis.
Right.
So would differ on that. Let us agree to differ on that.
I think from convincing patient point of view, I agree with Dr. Dhaval that if you have a report which says positive, it is so very easy to convince the patient.
Yes.
True to that. True to that.
So I think now we'll just brush in through our last case, which is that of an isthmosele. This is the new kid on the block, new age clinical entity. So this is another patient. We're ready to put in the embryos. The ultrasound shows an isthmosele with minimal fluid in the cavity. So just one quick take from everyone is that would you do you regularly prescribe to do isthmosele repairs prior to FET? If yes, what is your criteria? If no, why don't you? So I think Anupama ma'am, I think you're doing quite a lot of these. So just your two words.
I don't. Until unless it's an IVF failure, I don't repair isthmosele. Yes, if she comes from an IVF center and they say that you have not been able to get like IVF failure, then I repair isthmosele. This is my normally at my center I don't do isthmosele repair regularly for IVF patients.
Dr. Suyesha,
Depends upon everyone how they take it.
Dr. Suyesha, do you prefer to do repair all isthmoseles, or do you have a criteria? When would you send them to Dr. Anupama for repair?
Can't say. I mean, I can't take this question.
So isthmosele is a cause of secondary infertility because the niche of the isthmosele has blood accumulated in it. So which can hinder the implantation as well as cause the semen washout. So it is definitely a cause of secondary infertility, and depending on the residual myometrial thickness below the isthmosele, we can decide whether the patient has to be taken for hysteroscopy or laparoscopy. If the residual myometrial thickness below the niche is less, then the patient has to be taken for laparoscopy. Otherwise, it can be repaired hysteroscopically.
Yeah.
So it has to be repaired before planning embryo transfer.
I think it has to be, if you are looking at an infertile patient, it's better to repair it laparoscopically, because if we are doing it histoscopically, we are further thinning that area and making it weaker.
Yes, yes, I go by this. Dr. Nisha is absolutely right, because you have to do a laparoscopic repair for actually, because hysteroscopically you are thinning the area, so there's no fun.
Yeah. So what the evidence says is that the most important thing is to select the patient, which patient you want to repair the isthmosele. If there is intracavitatory fluid, then only go ahead and repair the isthmosele. Otherwise, if there is no intracavitatory fluid, the outcomes are not different at all, even if you repair it, if you don't repair it. If you there have been some studies which have shown that they've done hysteroscopic repair as well, because what they're doing is they're just lessening the slope for the fluid to accumulate. So maybe the inferior slope they want to, reduce a little bit. But definitely what is prudent is to do a laparoscopic repair and, handle these patients. So
I think that if you're doing it laparoscopically also, you're not going to affect the endometrial receptivity. That's
Dhaval, may I ask you a question? Can we, do you have any criteria of this much myometrial thickness or this much depth? You have to, then only you do isthmosele repair, otherwise leave it like that?
Ma'am, that is not my criteria. The criteria that what we follow is that if the transfer has failed, if she has implantation failure, if we can see fluid in the endometrium, but with various endometrial preparational techniques, that is the only time when we go ahead and do the repair. Otherwise, we just let it be, because we must have had countless patients of ours who've conceived with us who's had one cesarean section, but they have conceived subsequently as well. So, and also countless patients who've undergone a cesarean section for the first one, have undergone another embryo transfer subsequently and again conceived. So I don't think that, all isthmoseles are repaired. The problem is the fluid which is there in the cavity. So that if that fluid is there, try to change the endometrial preparation protocol, because sometimes, just by changing the protocol, the fluid might disappear. If it is still persistent, so then that is when you have to go ahead and look for a repair.
Oh. Thank you.
Thank you, ma'am. So
just a last thought, it's just out of the box thinking that, for hydrosalpinx, we cannot control the inflow of the fluid into the endometrial cavity. But for isthmosele, it is approachable. I mean, has anybody thought about, aspirating that fluid in the previous cycle and then doing FET in the next cycle?
There are chances of reaccumulation of the fluid in the isthmosele.
No, but you do it right in the next cycle, no?
Yeah, I think I've just missed out putting a few slides. I think
there are times when you can just aspirate it and do the transfer in the same cycle.
In the same cycle as well.
Okay, that's what I wanted to ask.
That I have tried. I have done it and I've seen results. But that's not because of isthmosele. It was just the fluid in the cavity.
Yes, my IVF specialist has also done this. The same thing.
Okay, okay.
There
So
was,
Yes, in fact,
there
we
was
do it quite frequently. If it is less, the amount is not much, then we can just aspirate and do a transfer.
right.
there was an interesting article that I came across, which was labeled as NIIT, which was non-invasive therapy for isthmosil, non-invasive isthmosil treatment. So what they did is they just gave a depot preparation for 3 months, and then they saw that after 3 months of down regulation, they saw that most of the in a lot of patients the intracavitary fluid disappeared. So that is also one option that is there. So I think so maybe try all the medical managements and all the alternative approaches, and then before you know go ahead and post these patients for repairs. Because in one of my patients, although despite doing a good repair, what we felt was good, she went ahead and then developed another scar ectopic there and then itself. We managed that hysteroscopically along with suction evacuation, and the next cycle she conceived in another few months she conceived spontaneously. So that was also there. So we don't know what is working, what is not working until we have, you know, a plethora of evidence. Until we don't have that, so maybe, you know, you have to just use these as, you know, your items of last resort, that, you know, when nothing else is working, so then maybe we think about that.
And you know, like Dhaval, hydrosalpinx has got clear-cut guidelines, clipping or occluding, but istomosil till now doesn't have guidelines. This means there are some gray areas.
Yeah.
So
Like
I
for
think
fluid also, if the fluid is less than 3 cc, you can still leave it and do a transfer.
So I think now we've just come to the end of this extensive panel. So just, you know, if I'd just like to take some few take-home messages from our expert, Dr. Ajay, and Kalyan sir, if he just wants to chip in a few, 1 or 2 more things before we wrap up this session.
Can you just stop the screen sharing, please?
Yeah, yes.
Yes, Dr. Ajay.
Dr. Ajay left, I think.
Ajay sir has left. He just gave a message. Many panelists have left. I must congratulate and give a big round of applause. This is the longest perfection series.
And
We are close. We are close to 5 hours. We had reached 4 hours 40 minutes, but Dhaval, you have made it the longest perfection series of the year.
Dhaval,
The most perfect one.
Yeah, and everybody was glued to the screen, and Kalyan sir and Dhaval, you were amazing. And this panel, I mean, there was not a single take-home message which was not relevant. It was seamless. Your topics were very, very practical. Your take-home messages absolutely clear. And your panelists were phenomenal.
So, Dr. Monica, we'll finish up with this small video. How much adenolysis you should do? Too much adenolysis is the most important complication, is rupture of the uterus. This patient has undergone hysteroscopic adenolysis at my place. Second setting, it was done in a conference in Mumbai, and she came me directly at 24 weeks with hemoperitoneum. Baby was inside the uterus, and only with the amniotic band, it was inside. Otherwise, baby should have been in a peritoneal cavity. And you can see this thin amniotic membrane, which is remaining much. So, too much adenolysis is not indicated whenever you are doing a hysteroscopic adenolysis for Asherman syndrome. And we have to go for a hysterotomy for this lady. Thank you, everyone, for a lot of inputs. And I like to thank Dr. Monica Singh, Dr. Jain Manisha for bearing with us for 2 hours for this panel. And I'm really thankful to Dr. Nisha ma'am, Dr. Anupama madam, Dr. Sueshna, Dr. Sushma Nigam ma'am, Dr. Yukti Bharadwaj, and I think Dr. Vishal, I think all other panelists have gone.
Thank you, sir.
Asha ma'am, thank you.
Thank you so much.
Thank you, Kalyan sir. Thank you, Dhaval sir.
Lovely
Thank you,
panel.
Monica
Dhaval
ma'am, for
Dhaval
making
has
it
done
be
all
a
the
part.
preparation.
And thank you to the team of
Monica ma'am, we have a small video to be played.
Yes, please don't leave it. We have got two important announcements, like, you know, those Marvel movies.
Dr. Sueshna.
We have
So
a
much,
post,
thank you.
something interesting for you. Welcome to Bhopal for Vice President Conference on 12th, 13th, and 14th of July. Can you play the video, Vishal?
It is playing.
It's playing. The audio is not there.
No audio, I suppose.
Audio is
Oh.
not there.
So we welcome you to the City of Lakes. This is the West Zone VP conference scheduled on 12, 13, 14 July. Kalyan sir and Dhaval, I invite you for the same panel.
Yes, sir.
It is
Yeah.
so interesting. We should do it live in a full hall.
The audio is there.
You send his WhatsApp video to us. It looks interesting, but it's not playing properly.
We can stop it now. Yeah, thank you, and welcome to Bhopal, all of you, and welcome to the next webinar we are hosting. This is the launch of Bhopal chapter of ISOPAB. On 23rd of April, we are hosting a webinar, the first webinar of Bhopal ISOPAB, and 24th, we are doing Symbiosis 10. We are completing 10 episodes of Symbiosis with Foxy, and this is going to be a very best webinar with the breast coming and Thank you so much, everyone. Thank you, all faculties. Thank you, Dhaval. Thank you, Kalyan sir, Suyesha, Anita ma'am. Anita ma'am, best wishes for the election. Thank you, Yukti. Thank you, Nisha ma'am, Anupama ma'am. Thank you, Shal. Sushma ma'am, thank you. Manisha, many thanks for all the efforts.
Thank you so much.
Thanks a lot.
Thank you
for the
Dr.
opportunity,
Thank you.
ma'am.
Dr. Monica and
Still
Dr.
have-
Manisha are seen daily on everywhere.
Thank you so much.
Sir, now we have become webinar girls. Thank you, sir. Thank you. Many
Dhaval, it
thanks.
was really
Have a
nice.
good.
Dhaval. Yeah.
Thank you. Thank you. Bye.
Good night, everybody.
Thank you.
Bye. Good night.
Thank you, Dr. Vishal. Thank you, Dr. Vishal. Bye.
Thank you.
Bye-bye.